We are started now.
Hello, everybody. I'm Rifat Falak, board member of Geriatric Dentistry and country ambassador of Federation of Special Care Dentistry to UAE. I'm delighted today to welcome you all, our esteemed council members, academicians, clinical experts, and all our talented student delegates present this morning. FSCD was born with a vision to include, involve, and integrate persons with special healthcare needs. Despite special care having been synonymous with children, the rapidly transforming population demographics heading towards the proverbial silver tsunami compel us to acknowledge that older adults increasingly fit the criteria of persons with special healthcare considerations. As a vital component of FSCD, the Board of Geriatric Dentistry is committed to awareness, training, and collaboration to elevate oral health related quality of life for the most vulnerable and underserved segments of our community. On this note, please join us for the auspicious Diya lighting ceremony. I would now like to call upon the Vice Chair of our board, Dr. Vinaya Kundapur, for her welcome address. Dr. Vinaya is a clinical assistant professor at UT Health San Antonio School of Dentistry, San Antonio, Texas, USA. Over to you, Dr. Vinaya.
Thank you, Dr. Rifat. Good morning, everyone. I'm honored to be here today as we gather for this important conference on geriatric dentistry. On behalf of the organizing committee, I extend a very warm welcome to all the esteemed speakers, participants, and the attendees who is going to share the passion for improving oral health care for older adults. As we know, the life expectancy is increasing worldwide. This underscores the critical need for the specialized dental care to address the unique challenges faced by this elderly population. As dental professionals, it's our goal to go beyond treating the oral diseases. We must advocate for the holistic care that can help us to understand the oral health that is closely linked to the overall health of the population, of this population. So collaborating with other healthcare providers, caregivers, and families is essential to ensure that we have the best outcome treatment for these patients. The main agenda, this conference serves as a platform to explore the latest research, techniques, and strategies in geriatric dentistry. Our goal is to exchange knowledge, inspire the innovation, and discuss very practical steps that are required to enhance the oral health care for older patients worldwide. I encourage each one of you to engage actively, share your experience, collaborate in the ways you can, and collectively elevate the standard of care for the aging population. Together, we can definitely make a meaningful difference in the life of our geriatric patients. Thank you all for being here today, and we look forward for a day full of insightful presentations and fruitful discussion. I would really like to extend a very warm welcome to you all and glad that you all are here today. Thank you.
Thank you so much, Dr. Vinaya, for your warm words. Since its inception in July 2022, each of our geriatric board members has contributed immensely with valuable inputs and activities towards our shared vision. Here is a fleeting glimpse of the same. Video, please. The e-magazine was crafted as a resource that helped us to record and collate not just scientific activities, but also insights from the diverse training and unique experiences of our globally spread out board members. Its digital format is a boon towards ease of broadcasting, not just to the FSCD board members, but also to our professional colleagues, allied healthcare personnel, NGOs, ultimately increasing the impact of our outreach efforts to benefit patients. In the coming editions, we aspire to continue enhancing value and engagement, and we are certain that the budding dental professionals will play a critically important role towards this goal. At this momentous occasion of the very first international conference of FSCD in the month of October, dedicated by WHO to aging with dignity, it's a proud privilege to launch this geriatric edition of our FSCD's e-Gazette. Can we please have the ribbon cutting? It's now time to sit back and appreciate the creative efforts of the 53 doctor teams responsible for the amazing poster submissions. But before we do that, I wish to applaud our subject experts, Dr. Iram Parvez, Professor at Jamia Millia Islamia Dental College, and Dr. Rizwana Malik, Professor, Jamia Millia Islamic Dental College, whose patience and untiring scrutiny made the task of ethical selection possible. Here are our poster presentations.
Dr. Rizwana, Dr. Aram, both are online. You can turn on your camera.
Very good morning to everyone. Very good morning.
Hello everyone.
Good morning.
Today I am here to present my poster on the topic the impact of edentulism on oral and general health of elderly people. As we all know that edentulism is the process of loss of tooth and it is considered as the normal physiological process during aging. But edentulism has negative impact on the oral health and the general health of the person. So I am listing some of the problems that are caused by edentulism. So first of all, the oral health issues that are related with the edentulism, as we can see, like oral mucosal disorders, it include all the pathologies and disorders that are related with the oral mucosa. As the tooth are lost from the oral cavity, the gums are now exposed to the external environment and they are now more prone to the disease. So as we all know that tooth loss process or the edentulism is also a painful and very frustrating process and it even very discomforting. So as the gums are now directly exposed to the environment, they are more prone to disease. Now the mastication is also altered and the old peoples, those are wearing dentures after complete dentulism, they also face many problems like denture stomatitis and the problems like inflammation in the palatal mucosa. Not only the oral health but also the general and social health are also affected by the edentulism, as the tooth are lost from the person lost from the person oral cavity. the person become more conscious about the facial appearance, and they lack their self-esteem because tooth are something that gives life to our smiles. So person without tooth are feel very insecure and separate themselves from the society also, as mastication is also altered, so the food options become limited for them, and these causes many deficiency problems also. The recent studies also show that edentulism also affect the cardiovascular health, and after complete edentulism many people are more prone to the cardiovascular disease. So as the dentist, I requested you all to use your more and more technology and advancement in dentistry to cure these problems. Thank you.
Afternoon, everyone. Our today's topic is dental caries in geriatric population. According to a DCI 2021 study, 85% of Indian population aged 65 to 74 has dental caries, one of the most common bacterial disease in humans. It results from interaction of bacteria, dietary sugar, and host factors leading to biofilm production. Now, why older population is at high risk for this? First and foremost reason is gingival recession, and it is the reason why root caries is more common than coronal ones. Other factors include salivary changes with xerostomia as its major symptom, with polypharmacy as one of its major causes, which is aided by decreased salivary flow and buffering capacity, hindering its remineralization potential. With decreased manual dexterity in age, in conditions such as arthritis, Parkinson, and further poor caregiver support and limited access to public health care in India makes it difficult for such people to maintain oral hygiene. Oral environment can also be altered due to other systematic health conditions such as diabetes and dementia. Diagnosis is aimed at finding any lesions that are present and assessing their activity and risk of progression. Various caries detection tools are: first one is visual and the tactile examination. Second is radiographic examination, that is very crucial for detecting secondary caries. And the third one is fluorescence devices like diagnostic that can assist in detecting early root caries. Now, how we manage and treat these caries? First, initial lesions are managed through non-surgical and the fluoride therapy, and extensive lesions are subject to surgical interventions in which the affected tissue is removed or replaced with filling material. In India, oral health is often seen as a secondary to general health, and dental care is sought mainly for pain relief or aesthetic purposes rather than the preventive ones. However, by addressing systemic health, improving oral hygiene, and using appropriate restorative materials, clinicians can effectively manage caries and improve oral health and quality of life of elderly patients. Thank you.
Good morning, respected judges. Today I'll be presenting on oral manifestations of nutritional deficiencies in elderly. Judges, as we know that our oral cavity is the first site to show signs of systemic diseases and nutritional deficiencies. Therefore, it is very important that regular oral examinations are done, especially for the elderly, to check early signs of health diseases. As I have shown in my poster, the nutritional deficiencies and poor oral health are interconnected. For example, if we see that age-related changes in tooth birth can lead to altered food preferences, conditions like hyposalivation make chewing difficult. Additionally, tooth loss and impaired oral health can force the elderly to consume diets that lack in essential nutrients like proteins, fibers, and vitamins. Also, conversely, if we see, nutritional deficiencies also impact oral health, as I have shown various oral manifestations of different deficiency. For example, if we take protein deficiency, it can compromise the structural and functional integrity of our oral tissues, which can lead to weakened teeth, delayed wound healing, and increased risk of oral infections. Similarly, medical conditions like anemia manifest themselves as uh, pale mucosa, glossitis, and regular stomatitis. There are also other examples which I have highlighted in the poster. The key takeaway which I have emphasized on my poster is that oral health and nutrition are deeply intertwined. Therefore, it is very important that regular oral examinations are conducted so that we can detect nutritional deficiencies early, which can prevent further complications. As future dental professional, it is our responsibility to promote awareness and ensure that elderly receive the proper care to maintain both oral health and overall well-being. As we know that as we know that the uh, nutritional deficiencies and poor oral health are deeply interconnected. Thank you, judges, for your time. That's all.
Greetings everyone, I'm Anupriya, BDA second year student from Postgraduate Institute of Dental Sciences, Rohtak. Today we will talk about the oral manifestations of dementia in the elderly. What is dementia? Dementia is a broad term used to describe a group of symptoms affecting memory, thinking, social abilities, and these symptoms are severe enough to interfere with the daily life. First of all, the causes of dementia and the types of dementia. Progressive brain cell death due to disease, brain cell injuries or strokes like in vascular dementia, and the genetic factor and age-related factors. Other types of dementia can be Lewy body dementia and frontotemporal dementia. Now, let's talk about the major symptoms of dementia. Amnesia, that is the loss of memory. Aphasia, that is loss of ability to speak. Agnosia, inability to recognize an object. Furthermore, asparagia, agnosia, and other personality and behavioral changes also. Now, it's interesting to explore how these dementia affect the oral health. As this is illustrated in this figure, dementia is a loss of cognitive function which will lead to the bad oral health. The impact on oral health can be dental caries, bleeding gums, plaques, foul-smelling mouth, tooth loss, stomatitis, and round mouth, that is xerostomia, due to the medications and the brain functionings. Difficulty in swallowing can be the major factor as well, which will lead to the pneumonia in the dementia patients. The preventions and measures which can be taken are simple and friendly communication with the dementia patient, vitamins and nutritional diets, toothbrushing techniques like new interventions, electric toothbrushes are also available in the markets. Techniques like channing, bridging, hand over hand, and yawning can also be used for the rigid dementia patient. Cooperative caregivers should be kept in the mind. They play a very important role in the care of dementia patient. Dental cares and low sugar diets and regular dental visits should also be there. Now, at last, I would like to conclude this presentation with the note: the kindness can transform someone's darkest moment with a blaze of light, and you will never know that how much your caring matters. Make a difference for another today, and thank you.
Aging is out of control, but the way you handle it is in your hands.
Today, I, Jigyasa Kapoor,
And I, Harushi Malik, the second year students of PGIDS Rohtak, feel extremely fortunate to be a part of this geriatric conference.
today we would like to shed light on how to give aging a different dimension and to transform it by integrating holistic healthcare practices.
As age advances, tooth undergoes various changes in its structure and composition. The parts which form the tooth, such as the enamel, dentine, pulp, and oral mucosa, undergoes changes, and these alterations can impact the overall oral health.
As we explore further, enamel deteriorates by showing loss in permeability, increase of brittleness, and dental fluorosis. Likewise, the neighboring dental tissues show functional changes like pulp stones, increase in dentinal hypersensitivity, dead tracts, and fibrosis in pulp. Gingivitis and lingual varices are the most prevalent manifestations.
This entails that age is just not a number. It can lead to serious complications as well. There's an urgent need to prioritize oral health in geriatrics.
The key considerations include comprehensive assessment, maintenance of denture care, regular dental checkups by staying hydrated, and oral cancer screening.
Following these tips, elderly patients can maintain good health and prevent various other dental diseases.
Aging and its maintenance in oral cavity is something to be aware of and to be taken appropriate actions timely. All patients, no matter their age, needs to be treated with respect, compassion, and empathy.
Life is short, smile while you still have teeth. Thank you.
Thank you.
Good morning, everyone. The topic of today's discussion is modern solution to age-old problems. Oral health is central to nutrition and socialization. two of the hallmarks of successful aging. Now, to introduce, according to demographic transition model, the developed countries are in the stage 3 and developing are in the stage 2, leading to a major population that comprises geriatric patient and needs more attention. So it falls in the category of a special care need. Along with the overall health problem, a geriatric patient also suffer from several oral health conditions, some of which may be associated with systemic health. So healthcare professionals need to work in a multidisciplinary approach towards the benefit of such patients. The primary objective is to create the awareness about the interrelationship of oral health and overall health and steps taken to minimize the oral age-related oral health changes. Causes include age itself, reduced immunity, habits such as tobacco chewing, several drugs taken because of systemic diseases, mental disorders, majority of them are associated with depression, the cutoff from the society, and the reduced need for taking oral health care. Physical weakness is there, dexterity problem is there, and oral hygiene maintenance is compromised. The key consideration towards treating such patient is empathy, which is the most important thing to be considerate about. Overall health management should be the prime criteria. We should motivate the patient more towards their oral health. Tell, show, do technique can be incorporated in our treatment plan because it is easier for them to understand. Now, how to prevent the severity of age-old changes? Collaboration of dental and medical practitioners at the earlier stages, frequent dental visits, oral hygiene maintenance instructions that should be properly given, atraumatic dental treatment experiences, treatment of xerostomia, which is very important. The patient, if the patient has xerostomia, there are very high chances that the patient will undergo the very bad oral health condition in the coming years. So the treatment of xerostomia by sevimilline or any drug should be started as early as possible. Nutrition counseling should be focused about. Now, Kenny Shea has provided 5-point geriatric dental assessment tool called OSCAR. O stands for oral, S for systemic, C for capability, A for autonomy, and R for reality. In this, the reality aspect is to be think about because it prioritizes it works on prioritization of the oral health, which is very less in aged individuals, and financial ability or limitations or dependence on others for the same. Now, for treatment planning, we should give the oral hygiene maintenance program should be very adequately followed by multiple fluoride visits, chlorhexidine mouthwash and rinses or sprays may be given. Electrical toothbrush or flossers can be provided to them. Caregiver training is very important. Teledentistry or remote monitoring can be done by dentist. Ergonomic dental chairs are very important for the uh, patients with limited mobility. Then, if they had to undergo any surgery, then it is important if it is helpful if they undergo laser assisted surgeries than general surgery. Customized dentures and implants are of value. Then, if any restorative treatment is to be given, minimally restorative procedures should be considered. Maintenance phase in older individual is very difficult and but should be taken care of. To summarize, it is important to understand the emerging need for specialization in geriatric dentistry and to educate the people about the challenges that might be facing in the future life. Thank you.
Good morning, everyone. Today we'll be talking about ageism in dentistry, an issue that many might overlook but has significant consequences for the quality of care older adults receive. Ageism in dentistry refers to discrimination, prejudice, or stereotyping of individuals based on their age. This can negatively affect how older adults engage with dental care, leading to poor oral health outcomes. In fact, the impact of ageism is evident in various health domains, from limited access to healthcare services to physical and mental stress, and even a lack of research participation for older adults.
That's right. and these consequences extend to both oral and psychosocial health. For instance, ageism fosters negative stereotypes about aging, leading to reduced self esteem and motivation among older adults to seek dental care. In addition, healthcare system biases, the lack of geriatric training, and assumption about affordability only reinforces this issue. To address this, we need to raise awareness among dental professionals and promote age friendly communication by tailoring care to meet the unique needs of older patients and fostering inclusivity. We can create a healthcare system that serves all ages equally.
Exactly. Countering ageism requires a multifaceted approach. Encouraging the involvement of older adults in healthcare decisions, raising awareness, and fostering community outreach can make a real difference. Let's work towards a more inclusive and supportive environment, ensuring that older individuals receive the quality of dental care they deserve.
Thank you so much for your attention.
Greetings to all. Welcome delegates. We both are presenting a poster on topic rehabilitation of an edentulous maxilla with a digitally fabricated metal reinforced denture opposing a mandibular fixed prosthesis, a case report. In prosthetic treatment with removable dentures, computer-aided design and manufacturing technology is nowadays commercially used to fabricate complete dentures. Maxillary arc is edentulous in this case, and mandibular arc is with fixed prosthesis. Primary impression was taken with irreversible hydrocolloid alginate. Secondary impression taken with light body. Digital framework was designed, and metal denture base was formed by the DMLS technique. After metal denture base formed by the DMLS technique, base pattern was designed. Then permanent denture base was cured. After that, followed by jolulation, prime, and this is the final prosthesis and insertion. These are the pre and post-operative view of the patient. To conclude, digitalization in denture making is a valuable tool for edentulous patients. Digitally, technology has the potential to reduce the laboratory procedure, time, and the amount of material needed to fabricate the framework and denture base. The CAD/CAM framework used for digital CVs has advantage in terms of high mechanical strength over the RPDs fabricated via the conventional method. Moreover, non-metal materials can be used. These are our references. Thank you. Thank you.
Good evening, everyone. Today, I, Dr. Shwini, and my fellow Dr. Purva, first year postgraduate students at ITS Dental College, Hospital and Research Center, Greater Noida. We are going to put some light on the topic endoperioral lesion through our poster presentation. Now, the question arises, what are endoperioral lesions? The interrelationship between periodontal and endodontic disease has aroused confusion, queries, and controversy. The lesion appears as localized circumscribed area of bacterial infection originating from either dental pulp, periodontal tissue surrounding the involved tooth, or both. Differentiating between periodontal and endodontic problem can be difficult. The nature of the problem is often the first clue in determining etiology of such problems. Radiographic and clinical evaluation can help clarify the nature of the problem. Now to our case presentation. A patient named Ajay, 49 years old, was referred from the Department of Conservative and Endodontics to our department with root canal treated teeth with respect to 4-6 and 4-7. He had a chief complaint of food lodgement in his lower right back tooth region. On examination, 8 mm pocket probing depth was recorded with no pain and mobility in the associated area. Clinically, grade 2 furcation involvement was observed with respect to 4-6 and 4-7. On radiographic examination, bone loss was seen as radiolucent area surrounding the tooth, so we planned a periodontal flap surgery with regenerative periodontal procedures. The flaps were raised and bone graft were placed along with amniotic membrane. To secure, 5-knot sutures were placed. The patient was recalled after 14 days for evaluation of gingival and periodontal status. Healing was uneventful. The patient is then recalled after 6 months and evaluation of periodontal status and bone regeneration was done. There was significant healing seen with a reduction in pocket depth. To conclude, In endoperioral lesion, the success of endodontic therapy is dependent on the completion of periodontal therapy.
Hey, I'm Harshita from the Department of Periodontology, ITS Dental College, Greater Noida. The topic of my poster presentation is blade versus light frenectomy. Frenum is a small fold of tissue that connects the lips, cheeks, or tongue to the floor of the mouth. Abnormal and hypertrophied frenum can cause diastemas, gingival recession, eruption abnormalities, as well as aesthetic and functional disorders of the lip. Frenectomy is the complete removal of frenum, including its attachment to the underlying bone. Conventional frenectomy with blade has been widely used. However, laser-assisted frenectomy is a recent alternative. The frenectomy techniques employed include conventional or classical frenectomy, Miller's technique, VY-plasty, Z-plasty, electrosurgery, and the use of soft tissue lasers. There are various types of lasers used, like the ND-YAG laser, diode laser, carbon dioxide laser, erbium YAG, and erbium chromium YSGG lasers. According to the current reviews, laser is less painful, there is minimum bleeding, provides a better visualization of the operative field, and causes less damage to the adjacent tissues. Advantages post-operatively are less scarring, faster healing, and minimum post-operative pain. Hence, I conclude that laser is a better option due to its intra and post-operative benefits for the patient and the clinician in terms of faster healing, fewer side effects, discomfort, and greater patient compliance. However, a higher learning curve is required for this technique, especially to calibrate the appropriate power of the laser. Thank you.
Hello everyone. Today, let me present to you the importance of oral health in older adults and how the oral cavity acts as a reflection of overall health. Oral cavity plays a crucial role in overall well-being, especially when it comes to the geriatric patients. Poor oral health can impact nutrition, social, mental, and even self-esteem. Research has shown that poor periodontal health are linked to an increased cardiovascular risk due to oral flora entering into the bloodstream. There is a bilateral relationship between poorly controlled diabetes mellitus and gum health. Oral stomatitis, ulcers could be related to some gut issues. Oral pain, cheilitis, glossodynia could be a manifestation of poor nutritional status or endocrine dysfunction. Dry mouth often could be caused by medications or salivary dysfunction in Sjogren's syndrome and thereby pose an increased risk of tooth decay and plethora of infections. Oral lichen planus lesions could be seen in organ transplantation. Oral candidiasis is a sure shot finding in poor general well-being or long-term hospitalized patients. Hence, oral cavity is a reflection of general well-being of a geriatric patient. Truly, oral medicine specialist can first-handedly diagnose a systemic condition based on oral findings. Hence, addressing oral health concerns not only enhances the quality of life but can prevent complications in systemic conditions in the geriatric population. Thank you.
Esteemed faculties and my dear colleagues, I am Dr. Naswan.
I'm Dr. Ansina.
It's an honor to welcome you all to our poster presentation titled Smart Technology in Geriatric Oral Health and Innovations for Improved Care. Oral health is a vital component of oral health and well-being, especially for older adults. They frequently face challenges in mobility issues, cognitive decline, and difficulty in accessing dental care. These factors contribute to poor oral health, which can severely impact overall health and diminishes their quality of life. Therefore, we need innovative approaches that not only address these challenges, but also promote independence of regular care. We would like to discuss few topics or smarter ways to improve the life of elderly. First of all, teledentistry. Teledentistry is a boon of modern era Virtual consultations allow elderly people to receive dental advice without leaving their homes, making it easier for them to access care. Although it is considered as a digital instrument, smart toothbrushes is one of the still recent innovations in dentistry, which helps in overall oral hygiene maintenance and plaque prevention.
The mobile applications like Profix are tailored in a way that sends reminder for dental appointments, brushing, flossing, and medication schedules, helping them to stay on top of their oral health. 3D printed dentures 3D printed dentures with high dimensional accuracy can be fabricated within a short period of time and fewer appointments. This ensures better fit and longer life than conventional denture. The smart denture monitors with embedded sensor, which provides data on pressure points, optimal fit, and wearing over time, is the smartest way to provide patient satisfaction. Oral wearable sensor as a real-time indicator of user's physical condition by monitoring dental disease, salivary biochemical parameters, and food intake with sensor to track oral health indicator. Utilization of technologies can improve oral health outcome in most efficient manner by ensuring user-friendly design. In conclusion, smart technology holds immense potential to transform geriatric oral health care. Thank you.
Thank you.
Good morning, everyone. Today, I'm here to discuss the transformative impact of nanotechnology in dentistry. Nanotechnology, the manipulation of matter at the atomic and molecular scale, has emerged as a transformative force across various fields, including dentistry. Nanodentistry offers innovative solutions for prevention, diagnosis, and treatment, leading to enhanced patient care, improved outcomes, and greater efficiency in dental practices. It is derived from the Greek word for dwarf, which allows for precise control at atomic level. This innovation stems from Richard Feynman's visionary 1959 speech, "There's plenty of room at the bottom." In dentistry, the applications of nanotechnology are varied, as in tissue engineering. We can regenerate oral tissues such as bone and periodontal ligaments, with nanoparticles improving the strain integration and mechanical properties of grafts. Nanocomposites, the incorporation of nanoparticles into dental materials, enhances strength, aesthetics, and wear resistance, leading to smoother surfaces that reduce plaque accumulation. Dental nanorobots. While still conceptual, these tiny robots could revolutionize oral hygiene by targeting harmful bacteria while preserving beneficial microflora. Targeted drug delivery. Nanotechnology allows for precise delivery of therapeutic agents to the affected areas, improving treatment efficacy for periodontal diseases and minimizing side effects. Preventive solutions. Antimicrobial nanoparticles and remineralizing agents show promise in preventing dental caries, effectively inhibiting bacteria responsible for tooth decay. Looking ahead, the future of nanotechnology in dentistry is incredibly promising. Concepts such as autologous tooth regeneration, enhanced aesthetics, and improved orthodontic appliances are on the horizon. As we dwell deeper into these advancements, we are moving closer to significantly improving the quality of life for countless individuals. Thank you.
A very good morning, everyone. Today's topic for discussion is silver smiles aging gracefully with silver diamond fluoride, or SDF, in geriatric dentistry, which is a gentle solution for geriatric smile. So let me just begin with silver diamond fluoride is a revolutionary treatment option which offers numerous advantages for geriatric patients who often face a lot of dental challenges. And today, due to the enhancement of various dental procedures, the scope for geriatric endodontics or geriatric dentistry has also improved a lot. So there are various benefits of silver diamond fluoride to be used in geriatric dentistry. It has remineralization effect. So it acts on demineralized dentin. So it is resistant to acid attack. It causes reduction and breakdown of dentin collagen, reducing the acidogenicity in chorionic bacteria or biofilms, which inhibits various enzymes like collagenases. And there have been various efficacy studies which have noted its adherence to the surface of enamel, which is shown to have inhibited the ability to produce acids and its potential to inhibit biofilm formation. SDF not only has inhibition activity, it also improves antibacterial effects against various carcinogenic microbes. So it is a non-invasive invasive therapy which is used in anterior regions, more cost effective, has anti-biofilm factors or properties, and is not toxic to living cells, and has the ability to remineralize the enamel, which is highly desirable. And the future scope includes a multi-centric approach or investigation with a bigger sample size, concentration, and composition, which can be standardized, and it has to be made accessible as a ready-made product. So more research has to be done with evidence, with more evidence and concentrations and interval applications. How does SDF act? It has dual mechanism of action. The silver component in it kills the bacteria and prevents further formation of biofilms, whereas fluoride prevents and reduces the demineralization process. It first originated in Japan in way back in the year 1960. So 38% of SDF contains 44,800 ppm of fluoride, and it is used in early childhood caries, xerostomia, dentin hypersensitivity, etc., especially which is seen in geriatric patients because of the level of the pulp chamber or the level of the dentin tubules or the structures of dentin tubules. It is contraindicated in irreversible pulpitis or pulp necrosis, or in the patients having silver allergy, in ulcerative gingivitis and herpetic gingivostomatitis. So basically, the silver ions, they cause a destruction of the peptidoglycan, which is a major component of bacterial cell wall, and causes the lysis of these cell membranes. And the silver ions may denature the ribosomes, thereby inhibiting the protein synthesis and causing a degradation of the plasma membrane. And this silver ion binds to the DNA bases. It causes its condensation and its ability to reproduce or replicate. So it prevents bacterial reproduction via binary fission. So on the organism, it has inhibition activity by acting on its enzymes or acting on its DNA mutation, and it releases fluoride ions, therefore helps in remineralization, and also eliminates the actions of matrix metalloproteinases or MMCs, therefore having a positive control over the dentin collagen. So how do you use SDF? So dispense the SDF into a tapping dish. Use proper isolation technique, air dry it prior to use. Then immerse this particular SDF with the help of a micro brush into a tapping dish. Then apply it on the lesion using the scrubbing motion. Allow 1 to 2 minutes for this to soak into the lesion and react with the lesion. And trust me, SDF has a very positive action on various processes. And I would like to conclude by saying that silver diamine fluoride, by repeated application at around 6-month interval, was shown to be effective in arresting decay of root surface lesions and lesions around the crowns, especially in geriatric patients or older patients. And various study outcomes support the use of SDF treatment for older adult patients who are frail, who have frailty, and who reside in nursing homes or dependent living facilities. Hence, I would like to finally conclude that yes, SDF brings out a beautiful and graceful smiles in older individuals. Thank you and have a nice day.
Crafting comfort, computer-aided design and computer-aided manufactured dentures for geriatric patients. Why digital? It takes fewer appointments, that is, it takes only 2 to 3 appointments, whereas conventional takes 5 to 6 appointments. It has more accurate fit and better retention. Since anatomically difficult landmarks are scanned using intraoral scanner, there is better reproduction of details, and hence these dentures are more accurately fitting, which reduces the amount of denture sores and traumatic ulcers. CAD-CAM PMMA is hydrophilic, which increases the amount of retention in patients with salivary dysfunction. It has less polymerization shrinkage, which leads to less movement of teeth, which further enhances the nutritional status of the patient. They are of uniform thickness, they appear more natural and do not interfere with speech. They have better fracture resistance because CAD-CAM PMMA has high modulus of elasticity, which increases the fracture toughness. They are smooth, which decreases the amount of staining, plaque accumulation, and microbial adherence. Since it has no residual monomer content, there is no acrylic allergy to the patient. The denture records are preserved. This is useful in cases of refabrication. Fabrication steps, intraoral scanning is done, 3D models are obtained, virtual phaseboard transfer is done, which uses reverse engineering. In first part, we take extraoral photographs of the patient. 2 points are marked on TMJ and 1 intraorbital point is marked. This is transferred to the software. In the second step, phaseboard on which maxillary impression has been recorded is scanned and uploaded onto the software. Once occlusal relationship has been established, teeth arrangement and setting is done, occlusal adjustments are made, and the denture is milled using subtractive manufacturing. Chairside CAD, it is an intuitive technology which is very versatile because it is compatible with a variety of intraoral scanners and 3D printers. This includes chairside scanning, sending it for designing, and obtaining final milled dentures. There are a variety of systems, namely Sirona, Seret, and Prograpent. CAD/CAM softwares are selected by the clinicians on the basis of their workflow, hardware compatibility, precision, and the degree of customization required. To conclude, CAD/CAM dentures have proven to be effective in geriatric patients because they have more accuracy, which further increases the quality and the functionality of the denture overall. Thank you.
Good morning to one and all present here. Today we'll be presenting a poster on the topic is digital dentistry a boon for geriatric patients. Dental appointments can be very lengthy and tiring and more so for the elderly. Digital dentistry helps overcome this. Classical impressions can cause patient gagging, and some impression materials like zinc oxide eugenol cause allergic reactions to some patients. Intraoral digital scanners avoid all these issues, provide patient comfort, and also more accurate results. With CAD/CAM systems and digital dentures, it is possible to fabricate the prosthesis which can be dentures or crowns within fraction of time, thereby eliminating the need of special trays and also reducing patient recalls.
Patient involvement can be there through chairside visuals. Possibility of voids or air bubbles is eliminated. Any inaccuracy can be adjusted chairside, and need for crown reinsertion and readjustment is also reduced. Teledentistry allows to make online appointments and consultation, so patients do not have to wait for long hours for consultation. Dentist has the advantage of giving immediate visual representation of completed proposed treatment, as they say, meet the mind before meeting the mouth. To sum up, digital dentistry has many benefits over conventional methods. Old age patients should receive this advanced, more accurate, time-saving method taking into account their health, comfort, and psychological state. Thank you.
This presentation is on the geriatric guide for complete denture. When it comes to a geriatric patient, they have a threshold of acceptability for the dental treatment. I'd say this is moldable, but not just by the efficacy of the dental treatment, but also by the early initiated dentist-patient communication. The patient education or the guidance is a whole package of queries that a geriatric patient might surprise the dentist with. Over to my co-presenter.
The most important concept that a dentist should discuss with the patient is the difference between the natural dentition and the denture. It is how the patient counteracts with their overwhelming feelings when they insert and breathe the denture. Any foreign object in the mouth can cause salivation due to the simulation of salivary glands, and this is completely normal for a new complete denture wearer. Initially, after wearing a denture, there could be a slight amount of speech distortion, which can impede with the normal speech. Daily reading practice should help with this. Chewing with complete dentures is a developed skill over time. Patients should be instructed on how to start chewing soft foods. Patients also complain of the loose mandibular denture due to the lack of their understanding. A normal tongue position should be determined by the dentist, as a mandibular denture has muscular boundaries. The patient fails to understand the retention and stability. Then, the patient should be instructed on how to use non-abrasive toothpaste and clean it, as unhygienic denture could cause problems like oral candidiasis. Patients are advised not to use things like retentive gums or paste available in the market, as it can cause damage to the oral tissues. With the advertising and marketing of such products, it can cause harm such as bone loss, including inflammation.
Good afternoon, respected judges. Myself, Hardik Gowda, the presenter of this poster. My topic for this presentation is changes in saliva with age. As we all know, saliva plays a crucial role in oral health, digestion, and oral well-being. Changes in saliva can indicate various health conditions. The key components of the saliva are water, electrolytes, enzymes, antibacterial compounds, mucins, as you can see on the left side of this poster. Common changes in saliva with age are quantity, consistency, pH levels. In quantity, it could be hypersalivation, xerostomia, and in consistency, the saliva could be thick or thin. The pH levels of the saliva could vary. It can become acidic and alkaline. There are also health implications if the saliva changes with the age. It consists of dental issues, digestive problems, infection risk. In dental issues, there will be increased risk of cavities and gum disease with dry mouth. In digestive problems, saliva is essential for proper digestion. Changes can affect nutrient absorption. Changes in saliva composition can also alter microbial balance in our mouth. Normal changes with aging are decreased saliva production affects chewing and swallowing. Dull sense of taste and smell may result in improper appetite. Absorption of vitamin and mineral decreases. Which conclusion for the poster is monitoring changes in saliva is important for maintaining oral and overall health. Consult a healthcare professional if you notice significant changes. Thank you so much.
Hi, I am Kushi.
And I am Harish, and we are from PGIDS Rohtak.
Our topic is Alzheimer disease and oral health. Alzheimer disease is a neurodegenerative disease of unknown etiology characterized by progressive memory and cognitive impairment. Many recent studies reveal a connection between poor oral health and Alzheimer's disease. Elderly people often present with cerebral cortical atrophy and show a significant increase in intercellular hyperphosphorylation as well as neuritic plaques containing beta amyloid. It progresses as person crosses 60 to 65 years of age. There is no permanent cure for this disease.
But do you know that this disease has a crucial link with our oral health? People suffering from such disease find it difficult to maintain their regular personal oral hygiene. But the question is, can poor oral health really cause Alzheimer's disease?
Yes, there is a surprising link between oral health and Alzheimer's disease. Research indicates that individuals with periodontal disease are at 1.5 to 2 times risk higher of developing Alzheimer's disease compared to those without periodontal disease.
Right at the gum line, where plaque builds up, hidden pockets can form, and these pockets can be a major site for bad bacteria to grow, especially the one Porphyria gingivalis. Porphyria gingivalis is a gram-negative bacteria, and this bacteria is also found in the brain of those individuals which are suffering from Alzheimer's disease. This bacteria emits a toxin causing inflammation in the gum. With time, this inflammation eats away all the bones, leading to the tooth loss and the periodontal problems. Thank you.
Good morning, everyone. This is Jigyasa Gemini, a third year dental undergraduate from Postgraduate Institute of Dental Sciences, Rohtak. Today, I am presenting a poster on relation between oral microbiota and cancers in aging community. As we all know, oral cavity is a home to variety of microorganisms which are now found to have a relation to the development of cancers in the elderly. The well-established culprits in this area are Fusobacterium nucleatum and Porphyromonas gingivalis. Other more common ones are Treponema and Prevotella species. But do you know how do they do that? They promote carcinogenesis by chronic inflammation, immune modulation, genetic alterations, and by producing metabolites which promote tumor growth. In this poster, I have covered 4 cancers which are now common in elderly. Increased risk of pancreatic cancer, malignant lung cancer, and breast cancer is found in people with higher levels of P. gingivalis. Colorectal cancer is associated with high lactobacillus and Rothia count. An increased risk of colorectal cancer was also reported in Treponema and Prevotella species. But new further studies are needed to define the correlation and the causation and the role of the confounding factors such as smoking, alcohol, and diet. This evolving field of study will now open new doors to better diagnosis, better knowledge of progress in cancer treatments, and better therapeutic approaches. Thank you.
Good morning, everyone. Myself Kajal and my co-presenter is Priya. We are the student of VDS second year from PGIDS Rohtak, and our topic is edentulism and CNS differentiation. As we all know, in geriatric patients, edentulism is a major health issue that possesses plenty of system health ramifications. One of them is CNS differentiation that impairs central reorganization of the sensory and motor cortices. As a result, impaired mastication forces the brain to undergo detrimental effects like periodontitis, cognitive decline, Alzheimer's disease, temporomandibular disorder, and many more. Here we have shown the graph that shows the relation between the cognitive impairment and the age group. As we all can see, in between the people of the age group 65 to 70, the edentulism is about 0.8%, and with the increase of the age, we can see within the people of the 100 plus age group, the edentulism increases to about 50.9%.
Now, I would like to continue with some clinical implications and recommendations that we can take, like prosthetic rehabilitations, cognitive training, nutritional counseling, early intervention and preventions. And now here are some of the research that are going in this direction are investigation the causal relationship between edentulism and CNS differentiations, effect of CNS differentiation on cognitive decline and dementia, connection between edentulism and Alzheimer's disease, and many more.
And now, in the end, I would like to say that teeth are not only for the beauty, they are effective too. Thank you.
Good morning, respected senior dental professionals. Myself, Fishy, and I am honored to present an e-poster alongside my co-author, Isha Malik. We are second year BDS students from PGIDS Rohtak, and today we'll be discussing the impact of fluoride in the geriatric dentistry.
Fluoride plays a key role in preventing these issues. It strengthens enamel through remineralization, making it more resistant to decay. It also helps protect exposed root and reduce dentine hypersensitivity by occluding dentinal tubules.
Let's take a look to how fluoride works in action. As you can see in the images before treatment and after the treatment, the enamel is improved and remineralization of strength and strengthening of enamel occurs. Can you please explain the type of fluoride treatment?
Certainly, fluoride can be applied through topical experiments like varnishes and gels or through systematic treatments such as fluoridated water. Each has its own advantage. Varnishes, for example, provide prolonged contact with the tooth surface, which enhance its effectiveness.
So now let's highlight some key benefits of the fluoride treatment. It prevents tooth decay, strengthens enamel, reduces sensitivity, combats xerostomia, and can reduce cavities by up to 50%.
Fluoride is generally safe for geriatric patients when used correctly. Some minor side effects like temporary sensitivity are there, but the benefits far outweigh any risks.
So concluding it, fluoride is a crucial part of the geriatric dentistry, offering an affordable and effective solution to preserving oral health and improving the quality of life of elderly patients.
Thank you so much for your attention.
Thank you.
provision of oral health services for older adults is multidisciplinary because it involves inputs from different specialities of dentistry, and it's multidimensional because of psychosocial issues, systemic health problems. There are three categories of older adults: the healthy elderly who seek treatment for themselves, frail and disabled older adults who have special needs, and the dependent older adults who have the geriatric giants. Now, this part, which I'm going to read now, step 1 onwards, is for the development. Measures required are appropriate knowledge and skills among dental professionals for provision of oral health services to older adults. So for this, the preparation of the curriculum is essential for the subject of geriatric dentistry, and then its implementation in the undergraduate BDS curriculum. And approval needs to be taken from the National Dental Commission. Next is simultaneously training of the paramedical staff, upgradation of infrastructure, and involvement of the manufacturing industry for dental equipment. Step 4 is the focus on early prevention in young adults in the 20 to 50-year age group to propagate good oral health in older adults of the future. So they should be intercepted early. This can be achieved through community programs, clinical practice, targeted chairside preventive strategies, and research to identify high-risk individuals. This can be from salivary parameters. They can be salivary biomarkers for periodontal disease, the gingival clavicular fluid, like collagenase. Concluding remarks are: for provision of oral health services to older adults, the hallmark is reliance on teamwork. Second, ultimately to develop geriatric dentistry as a postgraduate specialty. And third, the rationale is the goal for all this exercises for the goal of good oral health and better health outcomes for senior citizens. Thank you.
Good evening, respected judges. Today, myself, Sia from PGIDS Rohtak,
and myself, Muskan from PGIDS Rohtak, are here to present a poster on the topic Restoring Smiles, Role of Denture in Geriadontics. Dentures are basically those prosthetic devices which are constructed to replace missing teeth in lower jaw, upper jaw, or both at the same time, taking support of the surrounding soft and hard tissues of the oral cavity. Based on the differences in requirement of the patients, there are different denture designs. We have here complete dentures, snap-in dentures, immediate dentures, partial dentures, over dentures, economy dentures, custom dentures. Observing the variations in the requirement which every patient has, we can see the variations in different dentures. Now coming to the benefits of these dentures. Dentures, they not only restore the teeth in oral cavity, they also restore oral cavity functions, which are they improve chewing. So a person can cherish different foods, which also provide different nutrients to the person. They help in improving aesthetic appearances. They prevent the bone loss, which takes place from edentulism, and also dentures help in improving speech of a person. Now over to you, Sia.
So, to maximize the effectiveness, lifespan of dentures, proper maintenance that enhances the durability, comfort, hygiene should be ensured. So, there are some precautions that the patient should maintain while wearing the dentures. That they should brush the teeth, their dentures. They should avoid soaking the dentures in the hot water, and they should avoid using bleaches on the dentures. Now, with the benefits, there are some challenges also that the patient faces while wearing the dentures, and some of them are gum irritation. While wearing the dentures, sometimes the dentures irritates the gum, causing the pain and the soreness in the gums. Then there can be plaque formation on the dentures, and there can be some stains present on the dentures which can become permanent if the brushing is not done in proper time and in a proper way. So overall, by keeping the upkeep of dentures, patients can easily enjoy a higher quality of life with increased oral comfort, confidence, and overall health.
Good morning, all. We Nagarandani and Pavtarni CRA from KSR IDSR are hereby to present poster regarding importance of providing comfort to the geriatric patient while recording centric relation by Goti Tracy. Our aim is to evaluate conventional method used for recording centric relation versus conventional method through photobiomodulation. We are here to present our poster demystifying centric record with photobiomodulation. Okay, what is photobiomodulation? Photobiomodulation is nothing but it's a low-level laser therapy which plays an important role in the procedure of centric recording. Why are we using photobiomodulation in geriatric patient? And what's the disadvantages in conventional method we are seeing? While recording gothic arch tracing through conventional method, the patient's muscles become fatigued so that the patients are unable to give the proper movements during the procedure. Before recording the centric relation, photobiomodulation therapy acts as an analgesic, muscle relaxant. So this method will be quite comfortable to the patient and also for the operator to record the centric relation. And here we are using the Warfel scoring criteria for subjective evaluation for point-centric record. And here we are getting results. Warfel's analysis revealed that photobiomodulation improved mandibular function to achieve point-centric record. And here we are getting the inference as the centric record has been improved and deprogramming of the proprioceptive memory has been accelerated and the muscular conditioning has been enhanced and operated and the patient's fatigue has been minimized. Here, we concluding our poster, photobiomodulation is a revolutionary headway in removable prosthodontics. Thank you.
A warm and pleasant morning to one and all present here. Myself, Nurul Arifa.
Myself, Jane Atiksha.
Thank you for giving us wonderful opportunity to introduce ourselves today.
Today we are here to discuss a critical issue in dentistry and geriatric care. As dental professionals, it is essential for us to understand the use of multiple medications in elderly patients, their impact on oral health, and various treatment approaches.
So, what's polypharmacy? The administration of many drugs at the same time or taking an excessive number of drugs. Elderly patients usually present with multiple chronic diseases and are treated with multiple medications that might pose challenges in the dental. Coming to the prevalence part, over 40% of elderly patients are on 5 or more medications. Common medications such as hypoglycemics, antihypertensives, antidepressants, steroids, sedatives can lead to side effects such as xerostomia, dysgeusia, bleeding risk, periodontal disease, exacerbation, and infection.
Xerostomia can particularly be problematic as saliva plays a major protective role and reduced salivary flow can increase the risk of caries and as well as periodontal disease necessitating proactive dental management. Another hurdle that involves drug interactions can also complicate the dental treatment. The drug interactions can be like drug interactions or drug disease interactions.
Coming to the soul of the topic, we must focus on the strategies of management in geriatric patients. First and foremost, comprehensive medical history. Second, medication reconciliation. Third, collaboration with patient's physician. Fourth, modified dental treatment. And fifth, monitoring adverse reactions and regular follow-up.
Every dental hospital should have a ready-to-go kit with all the emergency medications, including oxygen cylinder, and it is best if we ask the patient to bring their appropriate medicines with them to the dental clinic.
We can perform following treatment procedures that also favors us in aspects of chairside time, minimally invasive procedures, and patient comfort. With adequate precautions in respiratory treatment, we can perform ART, SDF, simplified dental implants. And in periodontal therapy, we can do surgical, non-surgical, laser-assisted therapy. In prosthodontics, CD, RPD, implant-supported processes. And in surgery, we can do extractions. On concluding, the polypharmacy is common and not a contraindication for dental treatments in geriatric patients, prioritizing the medical issues and adequate consideration to be taken by any dental procedures. Thank you.
Warm greetings to everyone. I am Ayushi.
And I am Parvesh.
We are students of BDS second year at PGIDS Rohtak. We are here to present a poster titled Protecting Elderly Smiles, Tackling Periodontitis and Xerostomia.
Aging is a primary risk factor for the development of periodontitis and its serious complication, xerostomia, exacerbating alveolar bone loss and dryness of mouth due to inefficiency of salivary glands in geriatric population.
Moderate loss of alveolar bone and periodontal attachment is common in older individuals. Meanwhile, bacteria worsen the bone resorption around dental implants.
Age-related manifestations of periodontitis include receding gums, deep periodontal pockets, that is, deepened space between gums and teeth, inflammation and bleeding, plaque and tartar, and the most serious problem is xerostomia.
Treatment for periodontitis includes scaling and root planing that involves scraping of tartar from above and below the gum line, flap or periodontal pocket surgery. Here, the gums are lifted back and tartar is removed, bone grafting and soft tissue grafting.
Treatment for xerostomia include staying hydrated, chewing sugar-free gums, saliva-stimulating medications such as pilocarpine, fluoride treatments, mouth rinses, maintaining oral hygiene, and regular dental checkup.
Guidelines for geriatric population includes senior focus media such as newspapers, radio, TV programs, informing them about prevalence of electric toothbrushes and mouthwashes for their convenience. As all people can't keep their mouth open for long time and their hands also shiver while brushing.
Also, special discounts for them at dental clinics and free dental screenings would create a major impact in preventing periodontitis in senior citizens. Thank you.
Good evening, everyone. I am Rachita Sharma.
And I am Aarti Sharma.
And we are honored to present our poster, The Geriatric Dental Dilemma, addressing the facial and the dental changes. Now that we have introduced ourselves, let's explore the fascinating world of the geriatric population.
So, what is geriatric dentistry? Geriatric dentistry is a branch of medicine which delivers the dental care to older adults involving the diagnosis, prevention, and the treatment of the problems associated with the normal aging and the age-related disorders. As we age, our face and the teeth undergoes significant changes that impact our oral health, aesthetics, and the overall quality of life.
This poster will delve into the key facial and dental changes associated with aging, their implications, and the considerations for the geriatric dentistry. By understanding these changes, we can provide a better care for our patients and improve their overall well-being.
Now, let's move on the facial changes. As we age, our face undergoes noticeable changes like the bone resorption, soft tissue sagging, wrinkling, muscle mass loss, fat redistribution, decrease in the skin elasticity, and the nasolabial fold deepening, which affect the facial aesthetics and the oral function.
Teeth also undergo significant changes. So there are some dental changes like the tooth wear, periodontal disease, tooth loss, gum recession, xerostomia, etc.
There are some serious clinical implications associated with these changes, like difficulty with dental retention, increased risk of aspiration pneumonia, changes in the speech and swallowing, changes in the bite and occlusion, impact of nutrition, etc.
For these clinical implications, there are some treatment options available which include the dental implants, removable partial dentures, facial rejuvenation. So to diagnose and treat these changes, it is necessary for the dental professionals to have comprehensive knowledge about all the facial and dental changes associated with the geriatric dentistry.
With these words, we only want to mention that age is just a number. A healthy smile is timeless. Thank you everyone for your kind attention and have a nice day.
To one and all. I'm Pravina P. here to speak about my poster titled Doorstep Dentistry. Domiciliary dental care means provision of dental care outside a dental practice can take place in patients' own home, nursing home, and also in dental ward. Patients who are housebound, usually due to sanitary access issues, being bedbound. Patients with learning disability, autism, who find it very difficult to attend the dental clinic are treated in domiciliary dental care. Cost of domiciliary dental care is similar to the standard dental charges. The dentist and his team, dental auxiliary like dental nurses, additional clinicians, trained staff should go along with the dentist. Necessary dental instruments for the treatment should be taken without fail. The chair with mild position adjustments can be used. Patient's bed or mild reclining chairs can also be used for the treatment. The portable saliva ejector is taken and it is used to maintain dry working field. Clinical waste box should be taken for the disposal of waste after treatment. Emergency medicine like oxygen, drugs should be carried to the place. screening, diagnosis, scaling, series, RPDs, and rebasing and relining of the previous dentures can be done in domiciliary dental care. Minor fillings, fluoride applications, simple extractions can be performed. Advantages of domiciliary dental care is to give personalized care for the elderly patients and give them continuity of the care. And it is used to enhance the quality of life in the bedridden patients and in elderly patients. The limitations of the domiciliary dentistry are the dentist should always accompanied by the dental nurses or trained staff. It gives minimal treatment and it does not give any radiographic accessibility. The dentist should bring all the equipments in a trolley. That is very difficult for the dentist. It is concluded that the domiciliary dental care provides dental treatment at doorstep. For the elderly patient, though it has many limitations, domiciliary dental care is a good initiative to provide dental treatment for the elderly to enhance their oral health. The dentists need to be trained to perform domiciliary dental care in India, considering our aging nation. Thank you.
Hello, we are Reshma and Steffi, and we are here to present a poster on Mind and Mouth of the Golden Age. As we all know, dementia is defined as a clinical syndrome that is characterized by persistent progressive impairment of such high brain functions as memory, language, orientation, calculation, and spatial perception. Dementia and periodontitis is a two-edged sword. In periodontitis, there is passage of periodontal pathogens and inflammatory mediators into systemic circulation, which leads to inflammation, which gets transported to the brain via the blood flow, and it leads to dementia via three mechanisms. The first mechanism involves periodontal pathogens and pathogenic products causing microglial activation, neuroinflammation, which causes neuronal death and thus dementia. The second mechanism involves interleukin 1, interleukin 6, TNF alpha, which causes amyloid beta depositions and neurotic plaques in the hippocampus of the brain, leading to dementia. This also causes phosphorylation of tau proteins and neurofibrillary tangles, ending in dementia. The third mechanism involves vascular changes, which causes atherosclerosis thrombogenesis and cerebrovascular disease, ending in dementia.
Let's see how dementia causes periodontitis. Due to the cognitive decline, impassibility to maintain good oral health in dementia patient leads to the invasion of the keystone pathogens such as P. gingivalis, causes accumulation of the inflammatory cells adjacent to the periodontal pocket, leads to the destruction of the connective tissue and alveolar bone loss, which further leads to periodontitis. Dental care of the dementia patients include carer involvement, awareness of the effect of the dementia on oral health, considering treatment in smaller proportion, dental passport, individual behavior management, patient-specific treatment, recall interview at 3-month interval. Aging is not lost youth, but it's a new stage of opportunity and strength. Let's keep those teeth shining. Thank you.
Myself, Rishika, a third year BDS student, is going to present my poster themed on the topic Therapeutic Prospects of Dental Pulp Stem Cells in Alzheimer's Disease. For Alzheimer's, studies have shown positive bone marrow stem cell transplantation results for improved cognitive function. But now, dental pulp stem cells has shown to be the promising type of stem cells. This is being testified by various preclinical trials on AD rats. The results have shown high levels of three neuron related proteins DCX, that is linked to migration and differentiation of neuron, NF200 linked to stability of axon, and NEUN, which is a reliable biomarker for presence of mature neurons, as this protein is available only in the neurons. As a cherry on top of the cake, those AD rats also did show improved cognitive ability. Now, what makes dental pulp stem cells so much better? Well, better neuron differentiation than other cells. Their transplantation causes less tissue injury to the brain. They are readily available. Their extraction attaches no ethical issues. They also decrease neuronal death and they decrease amyloid beta induced toxicity. Now, continuing in this direction, stem cells from human exfoliated deciduous teeth should also be explored, as they express 2 times more number of genes. They have increased differentiation capacity and proliferation. Moreover, they are a medical waste. Right?
We need continued research efforts in this direction and measures such as establishing dental pulp banks, standardization of procedures, and scalability. Thank you.
This is Ritu Shiran here to present my poster on a novel screening test for cognitive and functional decline in patient using complete removable denture prosthesis, that is prosthesis presentation test PPT. In a study at Geneva, patients using CRDPs were asked to insert the prosthesis presented in an inverted orientation. The patient has the task to successfully correct the orientation and place the denture in the respective jaw. They reported that 24.4% patients failed the test. On comparing their MMSE, that is Mini Mental State Examination, and FIM, that is Functional Independence Measure, they reported that PPT was close to a subset of FIM but not MMSE. This can be attributed to the fact that FIM subset are not neuropsychological tests but are based on activities of daily life, and also PPT tests praxis, procedural memory, etc., which MMSC does not. PPT failure were associated with age but not sex. In the photograph added, the sequential failing of a patient in the mentioned study has been depicted. Further studies are needed to determine whether PPT can be used as a quick and easy assessment of the patient's ability to maintain the denture independently or as a screening tool in complement to MMSE. Thank you.
Hi everyone, good evening to all of you. I am Sachin, presenter, and Sahil Kakran, co-presenter of today's poster presentation. And we are from BDS 23 batch in PGIDS Rohtak. Today we are going to explore our PPT on age changes in oral mucosa. First of all, we discuss age changes like xerostomia, which is also known as drying of mouth, periodontitis, and thin smooth mucosal surface, loss of elasticity, and stippling occurs, and predisposed of traumas and infections. There are several more changes like atrophic of surface, nodular varicose, tongue has less papillas and deficiencies of vitamin B due to the deficiencies of vitamin B. There are further changes like physiological, morphological, functional. Physiological changes are increased keratinizations, reduced blood flow, reduced cellular renewal. You can also see in images increased keratinization. There are morphological changes like smoothing of tongue surface, increased visibility of blood vessels, change in mucosal color, pale or translucent with age. And there are functional changes like reduced cellular salivary flow, impaired taste and smells, and there is delayed wound healing in due to the age changes in older adults occur. And there are some clean factors affecting the oral mucosa due to the changes like nutrition and hydration, systemic disease like diabetes, lifestyle habits, smoking. And there are further clinical implications like increased risk of oral disease, impaired oral function, and difficulty with denture retentions. And there are diagnostic tools to diagnose the any infection or any more disease like salivary flow measurements because due to age increasing the salivary flow is decreased. And there are some recommendations: regular checkup of dental health, regular oral hygiene, and take salivary stimulants to older adults. There is references in given slide. This is all about today. Thank you so much. Have a nice day.
Respected judges, thank you for the opportunity to present my work. Today, I'll be presenting my poster which explores the connection between systemic health and oral wellness, especially in elderly individuals. This is a key issue in geriatrics, as maintaining both is essential for overall wellness as we age. This poster highlights how common systemic conditions like diabetes, heart disease, immune disorders
severely impact oral health. For instance, diabetes increases the risk of gum diseases, and cardiovascular issues can slow down healing. These complications become more pronounced as we age, leading to infections and eventually tooth loss. The key message is that managing systemic conditions helps prevent oral health issues. Regular dental care and monitoring of these diseases is essential, especially so in the elderly individuals. A holistic approach ensures that oral wellness is considered as a part of overall well-being. In conclusion, understanding the impact of systemic health on oral wellness is critical for improving the quality of life. Addressing both together promotes health as we age. Thank you.
Hello and good morning, one and all present here. The topic for our poster presentation is Nutrition Prosthodontic Care in Geriatric Patients. Proper nutrition plays a crucial role in maintaining oral health and can significantly influence the success of prosthodontic treatment. As older adults often face unique challenges related to oral health, like edentulism leading to difficulty in chewing, loss of perception, altered sense of taste, reduced salivary flow, change in food choices, which would ultimately affect the diet quality. Deficiency of some vitamins like B6, zinc, which reduces the immune response, vitamin A, which reduces salivary flow, affect the treatment plan. So, understanding the dietary needs allows the prosthodontist to create more effective prognosis. The physiological, psychological, functional factors affect the nutrition of the elderly, and pharmacological factors, which includes prescription drugs, which older patients often take, are the primary reasons for anorexia, xerostomia, taste loss, and interference with nutrition absorption. The modified food pyramid chart for geriatrics, as shown here, contains vitamin supplements at the top two. To improve the outcome of the treatment, dietary analysis and nutritional counseling should be done in geriatric patients as there is interdependent correlation between nutrition and prosthodontic treatment in geriatric patients. Thank you.
I'm Sridivya from BDS 23 PCIDS Rohtak.
Good morning, everyone. I am Nivedita Raman from PGIDS Rohtak from BDS 23 batch.
We are here going to represent our topic on role of dentist in identifying elder abuse. Now our topic is role of dentist in identifying elder abuse. What is elder abuse? An intentionally or negligent act that causes harm or distress to an older adult occur within a relationship when there is an expectation of trust. It can take various forms such as physical, emotional, sexual, neglect, financial, and abandonment. There are many causes and symptoms of elder abuse.
Causes of elder abuse are caregiver stress, financial exploitation, family conflict or disputes, cultural or society factor, power imbalance, isolation and dependency on the abuser, and lack of awareness. And the symptoms are unexplained injuries, emotional withdrawal, malnourishment, and dehydration.
And there are dental manifestations such as palatal bruising, torn labial frenum, alopecia, swollen lips, handprint on face. Then there are some prevention tips which are given by the dentist, such as education, guardian support, financial monitoring, reporting mechanism. And dentists here act as a screener by asking the questions such as, are you afraid of anyone from your family? Then there is a conclusion.
Elder abuse becoming more frequent as the population ages, recognizing abuse is paramount importance. Dentists are in an ideal position to identify and signal suspected abuse as they perform examination throughout head and neck. This is the main conclusion of the elder abuse. Thank you so much.
Thank you.
Good morning, ladies and gentlemen. We are here for presenting e-poster on implants in geriatric patients. Myself, Tamanna Rani, author of this presentation.
And myself, Karthik, author of this presentation.
As we all know that implants are increasingly recognized as a viable and effective solution of tooth replacement in a geriatric patients. Here is a detailed exploration of geriatric needs of implant, geriatric considerations, complications, procedural modification, and future directions. Geriatric needs of implants. It gives long-term solution, bone preservation, aesthetic benefits, and restore the functionality. Consideration while implantation in geriatric patients. Take medical history. Many older adults have a diabetes and osteoporosis, which can affect healing and implant success. Consider the bone quality and density. Age-related changes can lead to decreased bone density, which can affect the durability of implant. Medication effect. Many older adults are on a medication which can increase the bleeding risks, like anticoagulant drugs. Geriatric complications like implant failure. It is due to the poor bone quality. Peri-implantitis due to the inadequate oral hygienic practice and compromised immunity and delayed healing.
Procedural modifications includes minimum invasive surgical approach to reduce trauma and promote faster healing. Using simple ambient designs facilitate cleaning and maintenance. In case where the bone density is insufficient, preemptive measures like bone grafting should be considered. Future directions includes research on the long-term success rate of implants, technological implant advancements like 3D printing and digital planning tools, interdisciplinary approach, and patient education should be considered.
Thank you.
Hello everyone. Do you know India accounts for 20% of global oral cancer cases, with a significant proportion occurring in elderly individuals? Today, I, Tanushree, and along with my friend Nikhira, the students of PGIDS would be presenting poster which explores prevalence of oral cancer in elderly people. Now let's dive into the poster. Oral cancer. It is the sixth most common cancer worldwide. 40% of oral cancer cases in India occur among elderly people. Do you know our lifestyle choices like smoking, drinking, and poor diet silently inviting oral cancer? And stuff like cigar, alcohol, and especially tobacco are hidden risks of oral cancer. We cannot afford to ignore the link between HPV and oral cancer. High risk HPV strains such as HPV 16 and HPV 18 can cause genetic mutation leading to
Early warning signs of cancer include unhealing sores, point-shaped fractures, difficulty swelling, and pain. As the disease progresses, the symptom begins the movement in moving your jaw, pain, swelling, bleeding, and loosening of the teeth. Now let's look over the treatment plan that we could offer to elderly people. Early stage cancer is treated typically by surgery and radiotherapy alone. Transoral robotic surgeries and intensity modulated radiotherapy is also a safer alternative. A geriatric assessment is done prior to the treatment that include the evaluation of cognitive status, psychological status, and other medical condition of the person. The treatments are time intensive and requires expertise. As we know that prevention is better than cure, so let's look over the preventive measures that we could take to prevent oral cancer. They include regular health checkup, dental checkup, get vaccinated with HPV, maintain your oral hygiene, and most importantly, avoid smoking and tobacco. At last, I want to conclude my presentation by saying that support the fighter, admire the survivor, and don't forget that angels never give up. Thank you and keep smiling.
My topic for poster presentation is nutrition in geriatric denture patients. Proper nutrition is essential to the health and comfort of oral tissues, and health of the tissues enhance the possibility of successful prosthodontic treatment in older adults. Then importance of nutrition. Why is nutrition important? Malnourished denture-bearing tissues with friable epithelium and resorbed alveolar ridge, the denture wearer will complain no matter how well the denture is constructed. The thin friable epithelium covering the edentulous ridge may not be able to tolerate the forces imposed upon it by the hard acrylic base of the complete denture. The alveolar ridge may be so extensively resorbed that the processes rest directly upon the basal bone. Thus, a consideration of the nutrition of the oral tissues and the entire body becomes an important aspect to ensure success of the prosthesis. Then the factors affecting the diet and nutrition. There are various systemic factors and the oral factors that affect the nutrition status, such as xerostomia. Then the taste and smell sensation. The sense of the smell decreases with age, and above 40 years in females and 50 years in males, the sensitivity to taste is reduced as the number of taste buds are reduced. Then the dentate status, infectious conditions such as periodontitis, hormones, the dynamics of ghrelin, leptin, insulin, and incretin changes with aging, which is associated with loss of appetite in older adults. Then the nutritional assessment. There are various methods such as dietary evaluation, biochemical evaluation, anthropometric evaluation, clinical evaluations. The mini assessment is specifically designed for older adults. The MNA test consists of 18 items and takes less than 15 minutes to perform. Then the diet recommended for the geriatric denture wearer. First day post insertion, fruits and vegetable juices. Second and third day, juices and tender cooked fruits and vegetables. Fourth day, firm food can be given. So, I like to conclude by telling that it is imperative to know and assess the nutrition of our older patients to ensure final success of the processes. Thank you.
Hi everyone, this is Upanshu.
And I'm Suhani Yadav.
So, our topic is empowering older adults through effective gum care. Today, I want to talk about periodontal care in older adults. It's something I think it's really important because it helps prevent gum diseases, tooth loss, and promotes overall health by reducing the risk of systemic conditions like heart diseases and diabetes. Periodontitis is characterized by several symptoms that can be significantly impact oral health. Common signs include redness and swelling of gum, residing gums, bad breath, and bleeding gums. Now, the stages include the first stage is gingivitis, where the gums become inflamed, red, and may bleed. Next is early periodontitis, followed by moderate periodontitis, where the condition worsens, leading to tooth mobility and increased sensitivity. Finally, there is advanced periodontitis, which possesses risks for older adults characterized by loss of gum tissue and bone, resulting into loss of teeth. Now, Suhani will continue.
Periodontal care is crucial for older adults because it significantly affects their overall health. For instance, poor oral health can lead to cardiovascular diseases, diabetes, respiratory diseases, and cognitive decline. The treatment and care for the periodontal problems in older adults include the maintenance of the oral hygiene, rinsing with salty water, avoid eating hard and crunchy foods. The conclusion is regular dental visits is crucial to monitor gum health and perform healing. Thank you.
A very good morning to everyone. My name is Dr. Yashika Sharma, and let me walk you through my poster on implications of cold level laser therapy, that is CLLT, in oral and maxillofacial surgery. Starting with the introduction in the top left, cold laser or low laser are commonly used in dentistry because they allow us to provide painless therapy. The acronym LASER stands for light amplification by stimulated emission of radiation, and it produces light that is absorbed by tissues to stimulate healing. CLLT has been used for over 35 years in medical, dental, as well as veterinarian fields, but it remains underutilized despite its benefits in reducing pain, inflammation, edema, and promoting tissue healing. Moving to the mechanism section on the right, cold laser work through two mechanisms, that is biostimulation and photodynamic therapy. The laser light energy is absorbed by the mitochondria, which triggers the production of reactive oxygen species and nitric oxide. These molecules help reduce inflammation, promote cell growth, and activate specific transcription factors like NF-κB and AP1, which are essential for tissue repair. Now, if we move to the middle section where we discuss the clinical amplifications, cold laser are used in a wide range of dental procedures. For soft tissues, laser are effective in treating conditions like oral mucositis, lichen planus, and aphthous ulcers. They are also used in surgical procedures like gingivectomy, frenectomy, helping reduce recovery time and discomfort. For hard tissues, cold laser are applied in TMJ disorders, orthodontics, as you can see in the images at the bottom left, and even for dentine hypersensitivity, where a cold laser toothbrush can be used to treat sensitive issues. Cold laser are also used in third molar surgeries, promoting faster healing and reducing complications. In terms of intraoral surgeries, which you will find in the bottom right, cold laser are employed in implant placement, helping to improve healing post surgery. Additionally, they assist in endodontic diagnosis and even in surgical site irradiation after suturing to ensure quicker tissue recovery. Lastly, in the conclusion section at the bottom, CLLT is a powerful injective therapy in dentistry. It offers an effective solution for chronic pain management, accelerates the healing process for various oral conditions, and helps reduce the side effects of chronic diseases like diabetes. However, there is still a need to optimize parameters such as wavelength, remedy length, and dosage to maximize its effectiveness in different procedures. This poster summarizes how cold laser can improve patient outcome in both soft tissue as well as hard tissue and emphasizes its potential to revolutionize oral and maxillofacial surgery. That's all. Thank you very much.
Hi again. I'm sure all of you delegates must have thoroughly enjoyed the participants' poster session, which was extremely engrossing and enlightening. This now brings us to the final segment of outstanding entries of our paper presentations, which has made it a tough task for our respected judge panel of academicians, Dr. Esther Nalini, Department of Periodontics, KSR University, Tamil Nadu, and our senior clinician, Dr. Srinivas Karmat, past Vice President, IDA Mumbai, and honorary consultant for the Rotary Club Mumbai, to judge the best among these. I'd like to call them in, please.
Good morning, everyone. It's been a pleasure to be in this platform, and all the best to all the presenters.
Yeah, good morning, everyone. So nice to be on this platform, and I'm ready to listen to all the papers.
Thank you so much, Dr. Srinivas, for being here. Shall we now go on to start the session?
Yeah, during the presentation, I will turn off my video
Good
for
afternoon to
better
everyone
clarity.
present here. The topic of my presentation is the prosthodontic management of mucormycosis resultant defect from post-surgical phase to functional rehabilitative phase. Introduction. Mucormycosis is an invasive opportunistic fungal infection commonly affecting the immunologically compromised and had risen to prominence in the aftermath of the COVID-19 pandemic, with the rhinocerebral variant being of particular relevance to the dental practitioner. It is characterized by involvement of the maxillae, paranasal air sinuses, nose, and even the orbit. The disease is conventionally managed with surgical dissection and antifungal therapy. Reconstructive surgery may not always be feasible for the rehabilitation of these patients, in which case prosthetic rehabilitation may be resorted to for the restoration of the patient's ability to masticate, swallow, and articulate. The fabrication of a prosthesis, however, poses certain challenges, such as lack of favorable anatomical undercuts and the absence of a proper peripheral seal. This case report demonstrates comprehensive prosthetic rehabilitation of a post-mucormycosis defect from using an interim obturator to a definitive hollow bulb obturator. A 66-year-old male patient reported to the Department of Prosthodontics complaining of regurgitation of food into the nose while eating food. The patient gave a history of having undergone surgical treatment for rhinocerebral mucormycosis a month ago, and he is also a known diabetic and is on oral hypoglycemics. Extraoral examination showed facial asymmetry with depression of the left midfacial region. Intraoral examination revealed an elliptical surgical defect of approximate dimensions 5 mm by 2 mm involving part of the palate and the residual alveolar ridge corresponding to the region of the left maxillary canine till the left maxillary tuberosity. In addition, the retained roots of right maxillary second molar were present, and the mandibular arch was fully dentulous, and both dental arches had generalized gingival recession. Now, the treatment plan, since the patient had been on antifungal therapy with active purulent discharge from the defect at the time of presentation, it was decided to provide the patient with an interim obturator to facilitate per oral intake of food while the defect would heal completely and become dimensionally stable. A definitive obturator would be provided after that. It was also decided that the retained roots of the right maxillary second molar be extracted prior to fabrication of the definitive prosthesis. The absence of bone of adequate quantity and quality precluded the use of implants to augment the retention of the definitive prosthesis. The generalized periodontally compromised state of the dentition ruled out use of any crown retained precision attachments such as the Sagix or the vertex attachment systems. So it was planned to prosthetically rehabilitate the patient using a clasp retained definitive prosthesis with a hollow bulb using the anatomical undercuts of the defect for retention. So initially, an interim obturator was provided for the patient, and this is in the prosthesis in situ. This is the condition of the prosthesis a year after with periodic follow-up. And as we may see that the prosthesis had to be relined using tissue conditioners as the defect was healing and dimensionally changing over the course of time. Once the defect had stabilized, we had proceeded to make the primary impressions for the fabrication of definitive prosthesis. The primary impressions were made using irreversible hydrocolloid. The definitive impression was made using addition silicone impression material, followed by the recording of the maxillomandibular relations, which were mounted on a semi-adjustable articulator. This was followed by a try-in of the prosthesis, and this was the definitive prosthesis after acrylization. In order to reduce the weight of the prosthesis, a hollow bulb had been incorporated. To make the bulb hollow, the lost salt technique had been used, in which the salt had been incorporated into the bulb during the process of packing, and the salt was drained after acrylization by drilling a hole in the intaglio surface of the prosthesis and injecting water through that hole. This resulted in a decrease in weight of the prosthesis. This was the definitive prosthesis in situ and the pre-rehabilitative and post-rehabilitative frontal profile views. The discussion. Now, the prosthodontic management of maxillary surgical defects is done in 3 phases: the surgical, interim, and definitive. Surgical obturator is inserted during surgery, acts as a matrix to hold the surgical dressing. The interim obturator is placed at least 1 week following surgery. It is removable and can be adjusted during the postoperative healing period. Once the defect becomes dimensionally stable, a definitive maxillary obturator is fabricated. This is usually at 3 to 4 months after surgery. The treatment planning for prosthetic rehabilitation of surgical defects is guided by the morphology of the acquired defect, followed by the patient's aesthetic concerns and the financial situation. Now, a majority of the elderly post-maxillectomy patients are not suitable candidates for implant placement because of absence of bone of adequate quality or because of concomitant polypharmacy because of other systemic comorbidities. So it was decided to rehabilitate the patient using a removable clasp retained obturator, utilizing the anatomical undercuts to augment the retention and to incorporate a hollow bulb to reduce the weight of the prosthesis. The lost salt technique was employed for hollowing the extension of the obturator to the defect due to the relative ease and simplicity of this technique compared to other conventional methods. Conclusion: in terms of the patient's need for both aesthetics and function, this single piece fully hollow design used in this case proved to be an excellent rehabilitation technique and allowed us to maintain the prosthesis weight as low as possible. leading to greater patient acceptance of the prosthesis and overall improvements in mastication, phonetics, aesthetics, and the quality of life. These are my references. Thank you.
Greetings, everyone, respected judges and esteemed delegates. Today, I'll be presenting a case series on preliminary management of maxillary defects using interim obturator. Maxillofacial defects resulting from trauma, tumor resection, or congenital abnormalities can significantly impact a patient's quality of life, affecting ability to speak, eat, and maintain facial aesthetics. The use of maxillary obturator, which is a removable prosthetic device, can restore function and improve the overall well-being of these patients. The obturator acting as a barrier not only aids in functional aspect, but also help in preventing complications like oroenteral communication. After surgical intervention, the defect is blocked at the time of surgery with a surgical obturator to preserve the intact palatal plate and reduce the liability for infection. The interim obturator follows the surgical obturator. The interim obturator is a midway before the definitive obturator construction. The importance of interim prosthesis is to enhance the healing and to adapt the patient to the new health situation. This case series will describe the prosthetic rehabilitation of maxillary defect using an interim obturator. A 60-year-old female was referred for prosthetic rehabilitation of an acquired defect after surgical debridement of mucormycotic necrosis. Past medical history revealed that she had a known case of COVID-19 1 year back. Subsequently, she developed ulceration and pain in maxillary palatal region, which was diagnosed as mucormycosis in biopsy. Intraoral examination revealed Harmony class 1 defect on the left side. The entire heart, soft palate, and teeth were resected on the left side, leading to oronasal communication. On extraoral examination, the patient had facial asymmetry, concave facial profile, and loss of upper lip support on the left side. Definitive obturator prosthesis was not planned due to incomplete healing. On the intraoral examination, due to restricted mouth opening of approximately 18 mm, an interim hollow obturator was planned for the patient to prevent the nasal regurgitation of fluids. The primary impression was taken by using irreversible hydrocolloid material, which was then filled with type 3 dental stone to create the primary cast. For retention, adaptation of wrap around retainer for retention. The finishing and polishing of the prosthesis were completed. Adjustments were made based on the defect. The prosthesis was successfully delivered to the patient, meeting comfort, functional, and aesthetic requirements. Patient was examined at 3 days and 1 week after prosthesis insertion and checked for pressure spots and irritation. Follow-ups were arranged at regular interval of 1 month to make regular adjustment and modification to the obturator. A 47-year-old patient was referred to the Department of Prosthodontics for aesthetic and function concern after undergoing surgery for mucormycosis of the maxilla. 6 months ago, a surgical excision of the anterior and posterior maxillary alveolar bone was performed. Past medical history revealed that he had a known case of COVID-19 and then of mucormycosis 7 months ago. Intraoral examination revealed Harmony class 4 defect on the right side. Hard, soft palate and teeth were resected on the right side, leading to oronasal communication. An interim obturator was planned to prevent contamination of the oral cavity. The primary impression was taken by using irreversible hydrocolloid material, which was then filled with type 3 dental stone to create the primary cast. Adaptation of wrap around retainer for retention. The finishing and polishing of the prosthesis were completed. Adjustments were made based on the defect. The prosthesis was successfully delivered to the patient, meeting comfort, functional, and aesthetic requirements. Patient was examined at 3 days and 1 week after prosthesis insertion and checked for pressure spots and irritation. Follow-ups were arranged at regular interval of 1 month to make regular adjustment and modifications to the obturators. A 44-year-old male patient reported to the Department of Prosthodontics and Crown and Bridge in need of an interim obturator. Patient gave history of road traffic accident 6 months ago, resulting in oroenteral communication. Intraoral examination revealed Harmony class 3 defect on the right side. Oroenteral communication was evident. An interim obturator was planned to prevent contamination of the oral cavity. The primary impression was taken by using irreversible hydrocolloid material, which was then filled with type 3 dental stone to create the primary cast. The finishing and polishing of the prosthesis were completed. Adjustments were made based on the defect. The prosthesis was successfully delivered to the patient, meeting comfort, function, and aesthetic requirements. The patient was called up for follow-up at regular interval of 1 month to regular adjustment and modifications to the obturators. Following surgical treatment of the palate, prioritizing early prosthetic rehabilitation is crucial for effectively restoring oral function and enhancing facial aesthetics. Various types of obturator with different design and crucial in rehabilitation. To facilitate quick recovery of speech and swallowing, interim obturators are an excellent option that is less stressful for patients than other procedures. It aids in the transition toward a more permanent prosthetic rehabilitation for the patient to adapt and regain a degree of normalcy in their daily activities. A definitive obturator is not recommended until the surgical site has healed and stabilized dimensionally, and the patient is psychologically and physically prepared for any necessary restorative therapy. Dealing with a maxillectomy defect and providing an obturator prosthesis with adequate retention and function is a challenging task for any maxillofacial prosthodontist. We can conclude that it is important to take a multidisciplinary approach to the treatment process, considering all aspects of the patient condition and accounting for them in the treatment plan. By doing so, the treatment team can optimize the design and placement of the obturator prosthesis, leading to improved outcome for the patient in terms of both function and aesthetics. Overall, interim obturators are vital in bridging the gap between surgical intervention and long-term rehabilitation, facilitating a smoother recovery and enhancing patient overall well-being. These are my references. Thank you.
A warm greetings from my side to all the respected judges and dear delegates. The topic of today's presentation is integrating analog and digital workflow for fabrication of removable complete denture using neutral zone technique. The neutral zone technique is particularly useful for the patients with challenging anatomical conditions such as severe ridge atrophy, as it allows for more personalized and functional denture fit. The conventional denture fabrication for such patients presents significant challenges. Errors during the laboratory steps of teeth arrangement and curing are common and can severely compromise the success of complete dentures. The traditional methods rely on impression materials that may not be able to capture the precise details of the severely resolved ridges, which leads to the ill fitting of the prosthetics. Patients often experience soreness, ulcerations, and difficulty in eating and chewing due to poor adaptation of the denture. The digital dentures represent a breakthrough in the prosthodontic technology, utilizing CAD/CAM and 3D printing to create a highly precise and personalized dentures. This modern approach to fabricate denture offers new possibilities in personalized dental care and providing a functional prosthesis with greater efficiency and precision. This case reports describe the fabrication of 3D printed complete denture by integration of analog and digital workflow to rehabilitate the patient having severely resolved maxillary and mandibular ridges using neutral zone technique. So the 66-year-old female patient reported to the Department of Prosthodontics with the chief complaint of difficulty in eating due to unstable denture. She had an unpleasant experience with the previous denture, and she also gave the history of extraction due to chronic periodontitis 5 years back. So this is the intraoral examination revealed that the maxillary and mandibular ridges were severely resolved. So these were the treatment options that were given to the patient, and patient opted for the conventional denture. So the patient was given with the 3D printed complete denture using neutral zone technique. Maxillary and mandibular primary impression were taken using irreversible hydrocolloid material followed by the fabrication of maxillary and mandibular primary cast. The primary casts were used to fabricate the custom special tray to carry out the border molding step. The border molding was carried out using the all-green technique followed by the wash impression with light body material for both the arches. And the master cast was obtained from the secondary impressions, followed by the recording of maxillomandibular jaw relation. The maxillomandibular relation was then transferred to the mean value articulator to carry out the further procedure. The mandibular occlusion rim was replaced with the acrylic pillars to encourage the material to be used for the neutral zone recording. So this is the figure of the maxillary occlusal rim and mandibular denture base with acrylic pillars intraorally. The mandibular arch neutral zone was recorded using admix techniques, which utilizes the impression compound and green stick in the ratio of 7:3. The same step was carried out for the maxillary occlusal rim also. It was replaced with the vertical stops, and the neutral zone recording was carried out for the maxillary arch as well. So this is the final arch. This is the final neutral zone recorded maxillomandibular jaw relation. The recorded jaw relation was then scanned to obtain the virtual model. So this is the frontal and the lateral view of the virtual models obtained after scan. The teeth arrangement was carried out using the ExoCAD software, and it was assured that the teeth arrangement was to be done in the neutral zone only. After completion of the teeth arrangement, the overlapping of the previous jaw relation and the teeth arranged was done to verify if there is any sort of discrepancy. So these are the lateral view and the occlusal view for the same. Finally, the teeth after the verification of the teeth arrangement. So this is the final model, virtual model. The 3D printed trial denture was fabricated using the resin material, and it was checked intraorally for any sort of adjustment. And after that, this final finished and polished 3D printed complete denture for prosthesis was fabricated. So this is the pre-rehabilitative and post-rehabilitative extraoral view of my patient. And the patient was quite satisfied and happy with the new prosthesis. The post-rehabilitative instructions were given to the patients for rinsing the dentures and taking care of the oral cavity and the dentures as well. Patient was scheduled for follow-up after 1 week. After a week, prosthesis evaluation was done and pressure scores were checked. At consecutive visits, the patient was instructed to follow all the denture and oral hygiene practices. The integration of digital technology with the neutral zone technique represent the significant advancement in the fabrication of dentures. The digital flow enhances the precision, efficiency, and customization, while the neutral zone technique ensures that the prosthesis is positioned in the zone of muscular equilibrium for optimal stability and retention. By leveraging these two approaches together, clinicians can provide patients with more comfortable, functional, and long-lasting denture, particularly for those who face the challenges of significant ridge resorption. As digital technologies continue to evolve, the potential for even greater advancement in the design denture and fabrication will further improve the quality of care for edentulous patients. The future of complete denture prosthetics for resorbed bridges lie in the digital technology, and with ongoing advancement in the material, scanning techniques and 3D printing techniques, the dentures have a potential to become the new standard of care, offering both clinicians and patients superior outcomes. So these are my references. Thank you for your time.
The replacement of missing teeth with artificial substitute has been part of dentistry since many thousand years to achieve aesthetic, functional, as well as comfort factors. Dental implants have been used to restore completely edentulous and partially edentulous ridges with a predictable outcome. Dr. Brenmark, he forced the dentistry into a new era of reconstructive dentistry with a predictable success rate by the discovery of osseointegration. Here, the longevity of these implants mainly relies on the implant-bone interface. Of course, there are several factors which cause early implant loss. So, it is essential for an implant designed to have certain features so that it will distribute the stress effectively and evenly throughout the bone. The platform switched abutment design is one among them which will control the early implant loss. FEA can be used as a suitable tool to analyze the effect of platform switched design because researchers predict stress distribution in the contact area between cortical bone and implant as well as around the apex of the implants in the trabecular bone. The purpose of our study was to evaluate and compare stress distribution in the transcortical section of bone with normal abutment and platform switched abutment under vertical as well as oblique forces in the posterior mandible region. Methods include finite element modeling and finite element analysis. In the finite element modeling, we have these 5 steps. In case of construction of the geometric model, we have designed the bone as well as the implant. For the bone design, the CT scan of normal human mandible with no history of implant placement and with no history of pathological condition was taken using a CT scanner. Then the section of the bone was traced on the graph paper where X and Y coordinates contouring points were extracted and they were joined to form the partial volumes of the cortical and trabecular bone. Later, this section of the bone was extended mesially and distally in a Z plane to get the 3D model. For the implant design, we have selected the 13 mm length of implant and 5 mm diameter of the implant. Surrounding this tapered implant, the bone was constructed with the definitive differentiation of outer cortical and inner trabecular bone. Thus, we got a model of implant and bone. So, this model was duplicated to one more model. So, to these two models, we connected 5 mm abutment and 4.5 mm abutment to another model. These are the final constructed geometric model, one model with the 5 mm abutment and other model with the 4.5 mm abutment. And for the mesh generation, we have used HyperMesh software, that is ANSYS version 13. And for the accurate analysis of the program, execution of the result, we have used these material properties. These material properties were isotropic, homogeneous, and they were linearly elastic. And zero displacement constraint was placed at the boundaries of the models. And these are the number of elements and the nodes used for the final model. Once we created the models, the magnitude of force of 100 Newton was applied over both the conventional and platform switch model under vertical forces and oblique forces. After the application of the load, the stress which was generated in the cortical bone and in the implant was recorded. And these results were displayed by the post-processor of finite element software in the form of color-coded map using Van Mises stress analysis. These Van Mises stress were generated in cortical, trabecular, and implant regions were recorded. In the result, the stress distribution pattern which was generated in the finite model comes in a numerical values and they were recorded in a color coding. The maximum color was denoted by the red color and the minimum value was denoted by the blue color. The platform switched model has shown the minimum cortical stress compared to the conventional model under the oblique force of 100 Newton. And here also, the platform switched model has shown the minimum cortical stress compared to the conventional model under the vertical force of 100 Newton. And this is the bar diagram which shows the comparisons of values of Van Mises stress values in the conventional and platform switch model. Compared to the conventional model, the platform switched model has shown the less cortical Van Mises stress value. And this is the table showing the overall cortical, trabecular, and implant stress in both the conventional as well as platform switch model. The platform switch model has shown the minimum cortical stress compared to the conventional model. And again, this is the another table which shows overall cortical, trabecular, and implant stress in both conventional as well as platform switch model. Again, here the platform switch model has shown the less cortical stress compared to the conventional model. As we know, the platform switching means use of reduced diameter abutment on a larger diameter implant collar so that this connection will shift the perimeter of the implant abutment junction towards the central axis of the implant. What are the benefits of it? It will preserve the crestal bone loss, and it also increases the distance between the alveolar crest and inflammatory cell infiltration so that it will prevent the bone resorption. Here in our study, we have used FAA analysis because which will demonstrate the translation of simulated masticatory forces through the abutment to the implant and onto the surrounding bone structures in a 3D cross section of the mandible. And we have used numerical models because we can estimate the mechanical behavior of bone implant compound by the variables like stress and strain in the bone tissue, because these variables stress and strain cannot be measurable experimentally. And we have used 3D modeling here because which will give the high clinical relevance compared to the 2D modeling. And again, in our study, the trabecular bone was modeled as a solid isotropic material without any porosities, as it can be seen in vivo trabecular bone. And we have used commercially available size of the implant. And for analysis purpose, we have used vertical as well as oblique loading, as it can be comparable with the in vivo masticatory forces. So from our study, we could suggest that when the abutment diameter were reduced by either 10% or 20%, it results in less stress which is transferred to the crestal bone, regardless of the direction of force, whether it may be vertical or the oblique. With this, I would like to conclude the cortical Van Mises stress in the conventional model was found to be maximum compared to the platform switched model. Here, the stress was concentrated in the cervical region of the bone, and implant stress as well as overall stress was maximum in platform switched model compared to the conventional model. And the magnitude of stresses were decreased when the diameter of the abutment was decreased. In the final, the maximum Van Mises stress, compressive and tensile stresses in the cortical bone were lower in the platform switched model compared to the conventional model. These are the references for my study. Thank you.
Hello everyone. Topic of my presentation for today is treatment of calcified root canals in elderly. As we know that the population of elderly people have been increasing, and it has been estimated that people older than 60 years of age will double by 2050, reaching 347 million people. So, since there is an increase in number of elderly people, there is an increase in number of treatment needs also by them. Endodontic procedures specifically become very challenging in elderly patients because of a lot of reasons. And the first and foremost reason of that being root canal system being calcified or sclerosed. This happens in reaction to the lot of tooth wear which has happened over the years, restorative procedures, vital pulp therapies, regenerative endodontic procedures, leading to hard tissue accumulation within the pulp canal space at a slow rate. This has been termed as calcific metamorphosis or root canal obliteration or pulp canal calcification. Because of this, whenever you attempt an endodontic therapy in such a case, the chances of procedural errors such as access cavity perforations, ledging, missed canals, etc. increases multifold. Calcific metamorphosis appears as an absence of a canal or a very thin canal seen radiographically. However, micro CT studies have suggested the presence of a narrow canal, whether it is visible on the radiograph or not. Calcific metamorphosis can be of two types: localized obliteration, which is seen in one particular tooth related to trauma, and the prevalence of it ranges from 3.8 to 24%. However, in case of elderly people, because of attrition, generalized wear, repeated restorative procedures, we may see generalized obliteration leading to complete obliteration or a presence of a hairline thin pulp chamber and canals. There are many challenges which we face as endodontists when a case of generalized attrition or an elderly person comes up to our practice asking for a root canal treatment or requiring a root canal treatment. These challenges are pulpal calcifications, heavily restored teeth, periodontal diseases, attrition, abrasion, recession, in fact, communication challenges, complex medical history wherein there is involvement of a lot of systemic complications and medications, postural problems because of osteoarthritis, and in fact, even problems with rubber dam application, which hinders the complete isolation of the root canal space. As we age, there are a lot of changes occurring in our body. Similarly, is the case with pulp canals. The pulp space decreases, the water content of the teeth decreases, pulpal neurons, vascularity, cellularity decreases. However, there is an increase in the predentine layer of elderly people, occlusion of dentinal tubules, increase in cracks and crease lines, pulpal calcifications, cementum deposition, which shifts the minor apical foramen, and increase in collagen fibers also. So, when we talk about the treatment needs related to elderly people, increased tooth retention in elderly people have increased the treatment needs in this industry. But their priorities and their expectations are different from younger patients. Also, for them, the teeth are more related to functionality and diet, as we call it, rather than aesthetics. So increased anxiety and increased emotional needs of the patient are also there, which we have to take care of. However, if we successfully rehabilitate such patients, it has been reported that it results in improved oral health related quality of life. When you talk about diagnostic considerations of calcified teeth, it is important to know that in such cases, because the pulp chamber has constricted or receded, there is decreased dental sensitivity. Patient may directly report to you with painless pulpitis. And when you test them with vitality testing also, dry eyes may not give you a good response. So how do you diagnose So in such cases, electric pulse vitality testers are more of use because the decrease in neural nerve stimulation is not observed as yet. When you talk about radiographic interpretation of the canals, a preoperative radiograph is very helpful and useful before you start an endodontic therapy in such a case, because it tells you about the degree of calcification, it tells you about the size of the pulp chamber, it tells you about the root canal curvature, and sometimes, even if the canal is not very visible on the radiograph, it has been observed that the canal still exists, because that is why periapical disease is still there. CBCT has reported lot of studies have been reported with CBCT wherein canal detection has been possible, wherein radiographically those canals were not visible. CBCT also plays an important role because CBCT tells us the exact depth of pulp chamber, and as a clinician, we can use it as a reference point when we are looking for such canals. Now, when we are trying to locate the canal orifice, few of the requisites which are going to help us in giving a successful treatment outcome are preoperative radiograph, definitely, then surgical loops, and if possible, dental operating microscope and rubber dam. Only in cases where you are not so confident that application of rubber dam may cause you misdirection or disorientation and may result in access cavity perforation, that is the only situation wherein you can go ahead and do access cavity preparation, locate your canal orifices without rubber dam. However, once the canal orifices have been located, the rest of the root canal therapy has to be completed under rubber dam isolation. Other few tools which aid us are front surface mirrors, long tapered burr, endo-Z burr, ultrasonic tips have become very useful, Munz burr and DG16. So we have to identify where exactly is the depth of pulp chamber, and that depth has to be kept in mind when you are preparing your access cavity. Orientation and reorientation, repeated radiograph taking becomes an essential part of access cavity preparation of such teeth. Please, we should never ignore the visual clues which are related to the calcification, that is differences in color, texture, morphology, translucency of the calcified deposits than the normal dentine. Any areas of discolored tissue have to be probed with DG16 as they may represent a small puncture into the pulp space. So you can see in this picture that once the pulp chamber, once the pulp stone is removed, the canal orifices are clearly visible. Any drop which is seen or which is felt in case of opening of a calcified tooth should ring bells in your ears, because it may indicate a perforation. And the perforation can be confirmed either radiographically or through an electronic apex locator. Once the canal orifice has been located, half of the battle is won, because as we know that calcification is present more coronally than apically. Once the coronal obstruction is removed, usually the instrumentation is easier. But in fact, in case if you still find it difficult because of the fibrous tissue being present in the canals, there are many files which are available to us in the market which help us, such as K files, pathfinders, D finders, C files, and then modified K files. A buckling resistance activation technique has been described, which uses an engine-driven file with an active tip against the calcified tissue that is blocking the canal orifice. And herein the instrument is activated and the file is pushed in an axial direction against the calcification. When the progression of the file is achieved, the file is removed from the canal and the canal patency is established with a hand file. Another concept along with this is your continuous chelation concept. As we know that calcium ions present A major component of the dental canal calcifications, chelating agents are very important when we play a role of access cavity preparations or negotiations of calcified canals. So in continuous chelation concept, we use hypochlorite along with weak chelators such as etidronic acid rather than using EDTA, because continuous use of strong chelators such as EDTA may have decreasing or adverse effect on the mechanical properties of the dentine. So we use hypochlorite along with a weak chelator. In between, we can use strong chelators such as EDTA. So these are few cases wherein the calcified canals have been negotiated successfully with the help of the ultrasonic tips, microscope, surgical loops, and DG16. Sharing few cases along with, and with persistence, determination, perseverance, and patience, these teeth can be treated. So coming back to the guidelines for the treatment of calcified teeth in elderly patients, we have to keep in mind that we give short appointments. We use pillows for their back and neck being in comfortable position. Mouth props and bite blocks for patients who cannot keep their mouth open for a longer time. Magnification and transillumination to identify calcified canals. Rotary instrumentation so that we can reduce the treatment time. Care must be taken at the conclusion of the appointment to ensure that orthostatic hypotension should not develop. In the end, I would like to conclude that as long as the tooth is strategically important and can be saved, then endodontic treatment is very much indicated in a healthy and elderly patient. These are my references. Thank you so much.
A warm and pleasant greetings to all. I'm here to present my paper under the topic Smiling Seniors, addressing the barriers in geriatric dental care. Aging is a natural process. Old age should be regarded as a normal and inevitable biological phenomenon. This aging should be healthy and we should accept it as a milestone. So, what is healthy aging? Healthy aging is not only being disease free but the maintenance of functional ability in elderly patients. Why are we speaking about healthy aging here? It's because oral health and systemic health are interlinked and it is important for healthy aging. How can this healthy aging be achieved effectively? First, there are policies to improve oral health systems. National Dental Association supports policy makers to implement oral health policies. They formulate guidelines, organize community oral health promotions, and interprofessional trainings. In undergraduate curricula, we may include some basics on managing elderly patients. Individual healthcare professionals, along with medical colleagues, can provide multidisciplinary care. So, why should we be concerned about healthy aging? Because, as an individual, elderly people should enjoy their life activities, their quality of life should be enhanced, and they should lead a healthy life. They should be independent of their families. They should spend longer time with their family members, and this has a positive influence on grandchildren. They should participate in social activities. For this, oral health is important because oral health influence on other systemic conditions also. Oral inflammatory reactions can contribute to systemic inflammatory conditions. For example, as we all know, periodontal disease is the sixth complication of diabetes. It also has effect on cardiovascular system. Thus, oral health has an influence on systemic health. When we speak about cognitive health, increase in
Systemic inflammation increases dementia. Tooth loss causes decrease in nutritional intake, which results in impairment of central nervous system. As for nutritional health, hyposalivation causes chewing and swallowing function decrease. Oral disease has negative effect on appearance and social activities and hence reduce the quality of life for elderly patients. Now, coming to barriers that may cause lack of dental care to geriatric patients may include physically compromising conditions like limited mobility and transportation issues which make them difficult to access the dental clinics. Dental anxiety is a primary obstacle hindering patients of all age groups from accessing the necessary treatment. Visual and hearing impairment make it challenging for communication with elderly people. Financially, elderly people are dependent on their pension or on their children, thus making them to have a limited income, which may have an impact on their dental expenses. Commonly, elderly people are medically compromised and they are under multiple medication. As for dentists, fear of treating elderly patients and lack of experience and confidence are barriers from our sides. So, with these barriers, managing elderly patients should mainly include preventive management like regular dental checkups, and maintaining proper oral hygiene. Restorative management includes alteration in restorative materials and techniques. Periodontal problems are most commonly seen in geriatric patients, which should be managed conservatively and non-surgically. Surgical procedures can also be done in inevitable situations. Edential Edentalism is another common condition seen in elderly people, which can be treated by providing dentures. Solution for these difficulties can be given for both patient-related and dentist-related barriers, in which patient-related barriers can be solved by domiciliary dental care, mobile dental vans, arranging transportation facilities for elderly people. For dentists, more knowledge about geriatric conditions and improving skills on ability to approach geriatric patients can help them treat these patients effectively. To end my presentation, barriers and challenges are part of our dental practice. Hence, we should improve our skills to handle such kind of situations and find solutions to tackle them to provide an ethical and patient related treatment towards creating smiles. These are my references. Thank you for giving me this opportunity.
Hello everyone. The topic for today's presentation is to investigate the relationship between nutritional status and oral health related quality of life among geriatric denture wearers, which was an observational cross-sectional study. As we are all aware of that we are all in the process of aging and India is also aging gracefully. India has around 100 million elderly at present and the number is expected to increase to 323 billion, constituting 20% of the total population by 2050. And we should not be forgetting that oral health is a gateway to systemic health. And hence, we being prosthodontists, our main aim is to rehabilitate our edentulous individuals with some kind of artificial substitutes. As we are all aware that conventional complete dentures are the most commonly used rehabilitation procedure for our edentulous patients. However, dentures affect the chewing ability as it requires more strokes and time to chew food. And hence, there is definitely a problem with prosthetic therapy, and hence, the dental or the interprofessional team must be more aware of the negative effects and should also facilitate in dietary counseling to counteract them, to counteract the malnutrition which is commonly observed in our geriatric denture wearers. And hence, there is a need was felt to evaluate and determine the nutrition status and dietary intake on the oral health related quality of life of edentulous individuals who have been rehabilitated with complete dentures. Therefore, an attempt was made to assess the relationship between the nutritional status and oral health related quality of life among denture wearers. So the aim was to evaluate and determine the effect of nutritional status and dietary intake on the oral health related quality of life of elderly, together with the objectives to assess the need to include dietary and nutritional counseling during prosthodontic rehabilitation of elderly edentulous individuals. And hence, the null hypothesis tested would be that the nutritional status and geriatric oral health do not affect the quality of life of elderly patients. To continue with the methodology, the study was an observational cross-sectional study which was done for a duration of 3 months. The study setting was at the Department of Prosthodontics, and the source of data was also received from the Department of Prosthodontics outpatient department. So these were the inclusion and exclusion criteria of our patients. And the sample size, which was estimated to be around 110, using the sample size estimation formula. So the variables assessed were demographic variables, oral health rate, quality of life, and nutrition status of elderly. The ethical approval was obtained from the Institutional Ethics Committee before the start of the study. And this, you can actually see the mini nutrition assessment which was administered. It is a freely downloadable assessment questionnaire which includes the questions, 8 questions related to the number of meals, the food, the fluid intake, and autonomy of feeding. Together with this, it also gives us a quick score of the mini nutritional guidelines which is required for our geriatric individuals. A score more than 24 indicates that the participants have good nutrition status. Anything between 17 to 23.5 are at risk, and anything less than 17 score are in a dire state of malnutrition. We also administered a geriatric oral health assessment index questionnaire, which was actually developed by Hutchinson et al., which has 5 scores, which includes 1 being never, 2 being rarely, 3 sometimes, 4 often, and 5 quite often. And these were the common questionnaires, which was translated again in their local language to know the oral health requirement for our geriatric individuals. Let's come to the results and the discussion. The distribution of participants according to the demographic variables were around 110, of which the mean standard deviation was around 67.93. The standard deviation was around 4.8, and with the mean characteristics of weight being 63.04 among the male and female participants, with BMI being between 22.54. And these were the questions which were asked or assessed regarding the mini nutrition assessment to know the normal guidelines or the normal scores of the mini nutrition assessment, and accordingly they were actually scored. And these were the subject response, the frequency, and the percentage. When questioned whether there was any decline in the past 3 months in the loss of appetite, we had around 35% of participants explaining that there was difficulty in chewing. Weight loss was seen around 17%. Around 28% had loss of mobility, and there was some neurological problems in 35% of participants. When again questioned whether their food intake has declined over a period of time with a loss of appetite, there was 35%. Weight loss was observed in 22% of individuals, loss of mobility in 28%, and 35% had neurological problems. Distribution of participants on the MNA index questionnaire, these were the questions, and accordingly we had the participants who could actually assess regarding the other disorders which the patients normally were exposed to. So let me give you a quick review of a pie chart regarding the number of participants who were at risk of malnutrition. Around 49% were actually, though they were previous denture wearers, they were at a dire risk of malnutrition. Around 49% were classified as being at risk of malnutrition. Additionally, 9% of individuals are identified as malnourished. It was a good encouraging point that around 42% individuals exhibited normal nutritional status. Let me take you further through the GOHI score questionnaires. When questioned regarding the kind of amounts of food after dentures, 21% showcase that there was limitation in the kind of or the amount of food they have consumed. Trouble in biting or chewing, around 29%. Swallowing discomfort, around 62%. And dentures prevented them from speaking, which were accounted for around 10%. And when questioned regarding how often they will be able to feel discomfort when eating, around 15% up to 34%, and which limits contact with people, that is social contact was also limited because they're wearing dentures, around 6%. And whether they're using any medications to relieve pain or discomfort with dentures, around 14% were actually resolving themselves to some kind of medications. And these were the Gohai total questionnaire, the Gohai total when questioned, more than 24 were around 40%, and less than or equal to 24 questions answered correctly were around 60%. So you can actually see that the need for care was around 60%, whereas for the normal geriatric individuals who have been rehabilitated with dentures was around 40%. So there is a dire need of connection between the Gohai questionnaire and the malnutrition assessment after rehabilitating with dentures. Let me again take you further with chi-square assessment regarding GOHI and MNA. When the GOHI and MNA was correlated, it was actually seen that there was a strong correlation between oral health related quality of life and malnutrition in individuals with oral health concerns, and hence it was statistically significant at 0.001. So in this study of elderly population, the elderly with poor perception of their oral health status had a lower MNA score. 60% of the individuals were classified by MNA results as malnourished and required dental care according to general oral health related quality of life. So hence, there is actually future directions which is actually relevant for this current particular scenario. As we are all aware, the dietary intervention has been benefited patients with complete dentures as well as implant supported dentures. Individuals with fewer posterior teeth and those with no replacement of the missing teeth are also at a high risk of malnutrition. And hence, nutritional assessments, dietary counseling, and follow-up should be made mandatory as a part of undergraduate clinical training with the development of standard protocol for the same. There is actually a very important need for an interprofessional team, which includes policymakers, interprofessional bodies, public health professionals, academia, oral health professionals, and nutritionists to join hand to improve the nutritional and oral health status in our older adults. So these are my references. Thank you one and all for your patient hearing.
A very good evening and warm welcome to one and all. I'm Dr. Rukshi Nirani, and I'll be presenting a paper on the topic Rethinking Geriatric Dental Care, Direct Restorative Minimum Intervention Strategies. The extension for prevention traditional restorative approach advocated by G.B. Black does not help to address the ever-increasing number of complex restorative challenges in older patients. Minimal intervention dentistry is a philosophy that offers useful strategies for managing these restorative challenges, and geriatric MID uses a broad range of dental materials and instruments as appropriate for tooth preparation and restoration. MID can be considered across three phases: diagnostic, prophylactic, and restorative. The aspects of MID which routinely are used in geriatric dentistry are as follows. We have to consider the choice of the restorative material, which cannot be made until the caries removal is complete. And the field control has been evaluated. Conventional hand instruments, rotary handpieces, air abrasion, or lasers can be used. Other factors that affect the choice of the restorative material are aesthetic requirements, required longevity, and whether the restoration has to be replaced or repaired. Materials of choice are amalgam, indicated when less than optimal field control is present. Aesthetics are not of concern. Cusp restorations, restoration of subgingival areas, and difficult to access areas are to be restored. Composite resins are indicated where carious lesions are not deep and in areas where strength and aesthetics are of prime concern. Conventional and resin-modified glass ionomer cements are indicated for erosion and abrasion lesions, and in clinical situations where a field control is less than optimal, and areas where a highest fluoride release and recharge is required. For the placement of GIC, as with composite resins, use of a rubber dam, retractors, and or plastic or metal matrices and strips is recommended to ensure optimal placement. Both conventional and resin-modified glass ionomers require a seal. Either a varnish or a light-activated resin enamel bond can be applied. Another treatment strategy is that of the sandwich technique, which was described by Mount, indicated in areas where strength and aesthetics are of concern. The materials of choice are composites and resin-modified glass ionomer cement. With the closed sandwich technique, The internal glass ionomer is completely covered by the overlaying restorative material, whereas with the open sandwich technique, the internal glass ionomer is only partly covered. The next treatment modality is that of atraumatic restorative technique, which was introduced in the 1980s and has been defined as a minimally invasive care approach in preventing dental caries and stopping its further progression. It consists of a preventive and a restorative component. The preventive component consists of an ART sealant like GIC, which is placed in the pits and fissures, and finger pressure is used to complete the restoration, while the ART restorative component involves removal of caries infected dentine with hand instruments and the use of GI to fill the cavity. Compilation of studies which were done indicate that ART restorations nowadays are more effective in arrest of caries if resin modified glass ionomers are used instead of conventional ones. The next strategy is that of resin infiltration, which is indicated where there are early non-cavitated lesions radiographically limited to enamel or outer third of dentine. And the technique involves arresting progression of a carious lesion by perfusion of porous enamel with resin via capillary action. The next strategy is that of stepwise and selective caries removal. In 1979, Fusayama characterized caries dentine histopathologically as caries infected dentine and the caries affected dentine. In an attempt to preserve the tooth structure and pulp vitality, MID does not advocate complete caries removal to the hard dentine. Stepwise removal involves cleaning the EDJ until it has no discoloration and removing the carious tissue from the floor of the cavity until the soft dentine is reached. Temporary restoration is placed, and after a period of 6 to 12 months, after tertiary dentine formation, a long-term restoration is placed. As far as selective caries removal is concerned, it is a one-step procedure that involves cleaning the EDJ until it has no discoloration and then removing only soft infected dentine from the floor of the cavity, leaving behind hard affected dentine, which has the potential to heal and remineralize. Slot and tunnel preparations are another strategy that we can undertake for geriatric MID. They are conservative preparations and they can be effectively used. Slot preparations are indicated when a carious lesion is less than 2.5 millimeters from the marginal ridge. And materials of choice are GIC, composite, and amalgams. Tunnel preparations are indicated when the carious lesion is more than 2.5 millimeters from the marginal ridge, and the material of choice is GIC. Treatment of cervical lesions now consists of erosion, abrasion, abfraction lesions, and they are usually seen on the buccal surfaces, and patients complain of hypersensitivity. There are two treatment modalities for cervical lesions: remineralization and restoration. Remineralization consists of use of topical fluoride and non-fluoride caries preventive agents and amorphous calcium phosphate containing agents. Compilation of studies for use of fluoride shows that the use of these products is effective to cause arrest of caries in adult older patients. And similarly, a compilation of studies using non-fluoride agents state that chlorhexidine varnish is more effective as compared to chlorhexidine mouth rinse in arrest of caries in older patients. The restorative component is indicated where there is soft caries and cavitation occurs. Aesthetics is of prime concern, so the materials of choice would be glass ionomers and composite resin. Minimal intervention checklist for elderly patients, in summary, is basically to identify issues, prevent disease, undertake minimal invasion of the tooth structure if a surgical intervention is required, engage the patient and their caretakers in the treatment. I would like to conclude by saying that minimal intervention dentistry for the elderly patient emphasizes maximum interception of disease, beginning with managing risk factors, protecting at-risk tooth surfaces, and ensuring that the dentition can be cleaned and maintained. Thank you. These are my references.
A very good morning to everyone. The topic of today's presentation is management of sunken cheeks using digital dentures and 3D printed cheek plumpers with integrated attachments. Sunken cheeks can occur due to maxillofacial bone resorption, facial muscle atrophy, tooth loss. This can lead to an aged appearance and also can have a psychological impact on the patient. Conventional treatment approaches involves fabrication of cheek plumpers which can be retained by means of magnetic attachments which may weaken over time. Springs, they cause discomfort and are mechanically complex. Direct acrylic extension, they add bulk and affect the comfort and the aesthetics. Digital workflow in such scenarios offers precision using CAD/CAM for customized designs and 3D printing for efficient, accurate components, minimizing the need for chairside adjustments. A 70-year-old man presented to the Department of Prosthodontics with a chief complaint of difficulty in eating and a hollowed facial appearance. Extraoral and intraoral examination revealed sunken cheeks due to loss of buccal fat pads, along with completely edentulous maxillary and mandibular arches. The treatment plan involved the fabrication of CAD/CAM dentures and 3D printed cheek plumpers with integrated attachments. Digital scanning of the maxillary and mandibular arches were performed using an intraoral scanner. The resultant STL files were imported into a CAD software program to design custom trays. The area of the spacer adaptation was marked on the STL file of the mandibular arch, followed by an offset of 1.3 millimeter to create a uniform thickness across the marked region. A tissue stop was designed in the anterior crest region to ensure proper custom tray sitting. Then the entire tissue surface of the STL file of the mandibular arch along with the designed spacer was selected and given an offset of 2 millimeter to create a custom tray with 2 millimeter thickness. The maxillary custom trays was designed with a similar technique as that of the mandibular custom tray. The STL file of both the custom tray were then exported to a slicing software. Subsequently, the 3D printing of the custom trays were done using a biocompatible resin. Border molding and secondary impressions were made. These impressions were then scanned using a laboratory scanner. The STL files of these impression scan were inverted to create virtual mastercast. Then a virtual base was also added to the virtual mastercast. This was followed by designing of denture bases over the virtual mastercast, followed by their 3D printing. Then the jaw relation was recorded and the jaw relation was digitized using an external laboratory scanner. Then, after digitization of the jaw relation, a trial denture was designed in a CAD software, followed by 3D printing. When the trial denture was clinically evaluated and wax blocks were adapted over the buccal flange area of the trial denture, then the trial denture and the wax blocks, which were anatomically contoured, were scanned with the help of laboratory scanner. Then the scan of this trial denture and the wax block was superimposed with the trial denture design to transfer the cheek plumper area. This was followed by anatomically sculpting the digitally designed cheek plumper. Then these are the images showing the final verification of the cheek plumper adaptation. Then matrix and patrix attachment components were designed in the CAD software for the attachment of the cheek plumper. The total height of the matrix attachment component was 5.4 millimeter with a radius of 6.9 millimeter, while the total height of the Patrick's attachment component was 4 millimeter. The spherical portion had a radius of 1.15 millimeter, while the vertical component had a total height of 1 millimeter. Then the placement of the attachment components in the denture base and the cheek plumpers were done. Additionally, an anti-rotational feature was also incorporated in the cheek plumper design. These are the final images of the cheek plumper along with the matrix and the Patrick's attachment components. Then the final denture base and the cheek plumpers were 3D printed using a biocompatible resin along with the 3D printing of the final teeth. Then a silicone ring was placed in its slot in the matrix attachment component and cheek plumpers were attached. to the matrix attachment component with the use of the integrated matrix component. These are the images showing the insertion of the final denture. As evident in the pre and post rehabilitative views, there is significant enhancement in the aesthetics. So the clinical outcomes being secure attachment of cheek plumper using silicone ring system, and over a 3-month follow-up, minimal food lodgement was seen and no detachment of the cheek plumper was noted. The digital workflow provides several advantages such as precision in fit and design using CAD/CAM and 3D printing. Integrated attachment system enhances the stability and eliminates the need for external adhesives. Also, reduced chair side adjustments and minimal foot lodgement were some of the key highlights of this case. The challenges being it requires investment in advanced digital equipment and expertise, learning curve for digital process. Components like silicone ring may require periodic maintenance. To conclude with, this was an innovative approach for the rehabilitation of a geriatric patient with sunken cheeks. Digital technology was utilized, and CAD/CAM dentures were fabricated, and 3D printed cheek plumpers with integrated attachments were used, which provided a reliable and comfortable solution. In this case, the digital workflow led to aesthetically pleasant prosthesis, and minimal complications were noted over a 3-month follow-up period. These are my references. Thank you.
Greetings to all fellow experts. We are delighted to be a part of Geriadent 2024. We are pleased to present our paper on improving denture and oral hygiene in removable prosthesis wearers, evaluating the effectiveness of instructional leaflets and videos. In India, about 75% of people are partially or fully edentulous and need prosthetic rehabilitation. Majority of them choose removable prostheses due to economical constraints. Despite recent advancements in oral health care, awareness of proper prosthesis hygiene remains limited. Proper care of dentures is essential, not only for prolonging the lifespan of the prosthesis, but also to prevent several complications such as infections or periodontal diseases. Despite the critical need for effective oral hygiene practices, many denture wearers often lack adequate knowledge and skills to care for their prosthesis. In line with the conference's focus on raising awareness of dental care for the elderly with special health needs, our paper explores the effectiveness of instructional leaflets and videos as tools for improving the denture care and oral hygiene among removable prosthesis wearers. We aim to determine whether these resources can enhance adherence to hygiene practices, ultimately leading to better oral health outcomes. Our research seeks to provide valuable insights of dental professionals, educators, and caregivers to better support denture wearers in achieving optimal oral hygiene. Moving on to the methodology, the University Ethics Committee approved a study, and the study was registered in Clinical Trial Registry India. This cross-sectional study consisted of total of 40 participants randomized into 2 groups using computerized random allocation sequence. The postgraduate students in the department created a leaflet and a video to provide instructions on denture and oral hygiene for patients using removable prosthesis. A questionnaire was structured and validated to evaluate practice and awareness on oral and denture hygiene maintenance in these patients. Clinical evaluation of denture hygiene was rated according to Hodredick et al. Oral hygiene maintenance in patients wearing removable partial denture was clinically evaluated using OHI S index based on the established criteria. Oral hygiene maintenance in patients wearing complete dentures was clinically evaluated using denture stomatitis index suggested by Newton in 1960. At baseline, the subjects from both the groups were instructed to answer a questionnaire, and oral and denture hygiene was evaluated by 2 experienced clinicians. In Group A, the subjects were given leaflet with printed instructions, whereas in Group B, pre-recorded video was given for instructions. After a follow-up period of 7 days, the responses to questionnaires were recorded along with the evaluation of oral and denture hygiene. The data was analyzed using SPSS version 15.0. The p-value was kept at less than 0.05. Here are some intriguing results we discovered in the study. Around 40% of our subjects have been using the prosthesis for around 3 to 6 months, and almost 30% of them have been using it for more than a year. Majority of our subjects were complete denture wearers. 100% of the study population were given post-insertion instructions post-delivery of the prosthesis. Here, majority of them received these instructions verbally. Around 40% of our subjects used brush with soap water to clean their dentures. 50% of the subjects clean their processes twice a day. Only 15% clean their processes after every meal. 55% of the subjects responded that they did not brush their gums, tongue, and roof of the mouth. Only 7.5% of the subjects knew about denture cleansing tablets. 15% of the subjects still slept with their dentures in their mouth. 55% of the subjects didn't even were aware about the ill effects of wearing dentures at night. 70% of the subjects were not aware about the stains that are caused due to smoking or pan chewing or consumption of tea and coffee. In return leaflet group, there was significant difference between the baseline to follow-up data with the denture hygiene index. Similarly, in videotape group as well, there was significant difference from the baseline to follow-up data with the denture hygiene index. The results obtained from previous studies showed that the patients did not receive proper denture cleaning instructions from their dentists post-denture delivery. Awareness regarding certain factors like storage of denture in water and to clean the processes daily are given, but the mode and frequency of cleaning these were not given. Improvement in awareness is seen in the maintenance of oral hygiene, avoiding nocturnal wear of dentures, usage of denture cleansing tablets, avoiding staining products like tobacco, etc. The results showed that providing the video or leaflet with the instructions definitely improved the practice and awareness of oral and denture hygiene. The denture and oral hygiene instruction video recorded for the study was as effective as the leaflet that was delivered to the patients post-denture delivery. Both the modes of delivery seemed to be effective in delivering the instructions to the elderly patients, resulting in significant improvement in their knowledge and hygiene practices related to oral care and dentures. The clinical significance of the study lies in its potential to enhance the quality of care for elderly patients who use removable dentures. By demonstrating that both instruction leaflets and videos effectively improve knowledge and hygiene practices, the findings support the integration of these educational tools into routine dental care. This could lead to better oral health outcomes, reduced risk of complications, and furthermore, the study highlights the importance of tailored educational approaches for vulnerable populations, ultimately contributing to improved oral health and well-being in elderly denture wearers. These are our references. Thank you all for providing us with this platform to share our findings.
Good morning to all. Today my presentation topic is prosthodontic rehabilitation of post-surgical maxillary defect using a digital technique, fabrication and clinical outcome. Introduction. QCL denture are the type of denture that allows the preservation of remaining natural teeth, unlike conventional dentures that require the tooth extraction and coverings. QCL denture retain the natural teeth, further improve the stability and support. Introduction of digital technologies such as a CAD/CAM and 3D printing dentures improve the design, fabrication, enhancing precision and customization and efficiency. Advantage in 3D printing denture in QCL denture. Accurate CAD/CAM modeling allow the optimal fit around the natural teeth, faster production time compared than traditional techniques. Denture can be tailored to the patient-specific needs, including gum coloring, tooth shape, and alignments. Potential reduction in overall cost due to the fewer clinical visit and less chair time. Case report. 48-year-old female came to the Department of Prosthodontics with a chief complaint of missing anterior teeth due to the maxillectomy performed 6 months ago as a result of mucormycosis, difficulty in chewing, and aesthetic concern due to the missing maxillary anterior teeth. She expressed interest into comfortable denture solution that would allow her preservation of remaining posterior teeth. These are the extraoral views. These are intraoral view. Diagnosis and treatment plan. Diagnosis: RMNE class 6 maxillary defect and retained posterior teeth with a sufficient periodontal support. So treatment plan is to provide the patient with a stable, comfortable, and aesthetically pleasing solution while preserving the remaining posterior teeth. QCL denture is the better option for that. The workflow started with conventional technique. Primary and secondary cast is made with the conventional techniques. After the master cast was created, it was scanned using a high-resolution lab scanner to digitalize the cast. The scan data was then imported into the CAD software system for the designing of denture base of QCL denture. This is 3D printing denture base, and the jaw relation was performed. Using a jaw relation record, the trial denture was designed digitally with the same 3D model. The missing anterior teeth were digitally set according to the patient desired aesthetically and functional needs. 3D printed trial denture with and without support. The trial denture was evaluated for the aesthetic, phonetics, and occlusions. Based on the successful trial denture, the final design was completed using a CAD software. These are the final denture. The final 3D printed QCL denture was fitted to the patient. Minimal adjustment were the required, and the patient report the excellent comfort and fit. These are the pre-operative and post-operative extraoral view. Pre and post-operative lateral view. The outcome is that the 3D printed anterior teeth restored to the patient's smile, and the patient was pleased with the natural appearance. The function is the retention. The remaining posterior teeth ensure the excellent stability, allowing the patient chewing and comfortable. Patient satisfaction. The patient expressed the eye satisfaction with the overall fit, comfortable, and aesthetic of the 3D printing QCL denture. Discussion. The use of 3D printed QCL dentures offers the modern approach to the prosthodontics rehabilitation of partially edentulous patient. Unlike traditional method to rely on the manual techniques to fit around the natural teeth, the 3D printed denture base provides the exceptional precision and customization. By the digital design, the denture was exact contour of the patient oral anatomy and retain the teeth are captured, result in the better fit and reduce the need for adjustment. After the 3D printing of the denture base, a soft liner applied around the natural teeth provide the cushion, snug grip to enhance the retention and minimize the irritation. The aesthetic rehabilitation provides the 3D printed QCL denture can have a transformative effect on the patient appearance and confidence. This improves the aesthetic, not only the restore the function, but also boost the patient self-image, leading to improve the social interaction and quality of life. The psychological benefit is further reinforced by the retention of the natural teeth, which can foster sense the preservation of oral health and personal identity, contribute the greater patient satisfaction, and provide outlook to their prosthodontic rehabilitation. Challenges and limitation. Not all 3D printed material are ideal for the long-term wearer. Ongoing improvement in durability are needed. Initial cost. High upfront of cost in 3D printing equipment for the dental practice. It requires the exported in digital designs and 3D printing techniques. Patient adaptation. Some patients may take longer to adapt. Conclusion. This case demonstrated that 3D printed QCL denture offer a customized patient-centered solution for the edentulous patient with the retained natural teeth. The combination of digital precision, biocompatible material, and soft tissue preserving leads to the high level of patient satisfaction and functional improvement. These are my references. Thank you to all.
Hi everyone, I am the presenter of the presentation Personalized Periodontal Care for Geriatric Patients. Without further delay, we can move on to the slides. So today I am concerned about these topics. So as individuals age, their oral health needs change significantly, requiring personalized care to address the age-related challenges. So geriatric patients often face unique dental concerns, including increased risk of periodontal disease, compromised oral hygiene, and systemic health conditions that impact their oral health. So this presentation will delve into the critical aspects of providing personalized periodontal care for the older adults, exploring the latest advancements in treatment and the vital role of interdisciplinary collaboration. Understanding the unique needs of older adults. Providing personalized periodontal care for geriatric patients requires a comprehensive understanding of their unique needs and challenges. So, the older adults may experience a range of physical, cognitive, and social factors that influence their oral health, making it essential to tailor treatment plans to their specific circumstances. So, the factors include physical limitations, polypharmacy, cognitive decline, and social factors. Age-related changes in oral health. The oral cavity undergoes several changes with aging, affecting both the structure and function of the teeth, gums, and supporting tissues. So these changes can significantly impact the periodontal health and increase the risk of developing periodontal disease. So understanding these age-related alterations is crucial for providing personalized periodontal care for the older adults. So here is a differentiation between the younger adults and the older adults. So increase the risk of periodontal disease in geriatric patients. So older adults are more susceptible to periodontal disease due to a complex interplay of age-related changes and the lifestyle factors. So these changes can weaken the body's defenses against the oral bacteria, leading to increased inflammation and bone loss around the teeth. So understanding these risk factors is crucial for early intervention and personalized treatment. So the risk factors include the weakened immune response, reduce the salivary flow, chronic health conditions, and medication side effects. So challenges in maintaining the oral hygiene. So maintaining optimum oral hygiene becomes increasingly challenging for older adults due to physical limitations, cognitive decline, and other factors. So this can lead to a higher risk of periodontal disease and overall health issues. So the personalized care and support are essential for empowering the geriatric patients to maintain a healthy smile. So the challenges include dexterity and mobility, cognitive impairment, oral health condition, and accessibility. So customized treatment approaches. Geriatric patients often require a tailored approach to periodontal care due to their unique needs and health conditions. Treatment plans should be individualized, considering factors such as overall health, medical use, and functional limitations. So the goal is to provide effective and comfortable care while ensuring long-term oral health. So non-surgical treatment. So this approach focuses on controlling the inflammation and preventing the further bone loss. It includes techniques like scaling and root planning, which remove plaque and tartar from the tooth surfaces and below the gum line. Surgical treatment. So when non-surgical methods are not sufficient, surgical procedures may be necessary. So these procedures aim to reduce the gum pockets, regenerate the bone, and improve access for cleaning. Examples include gum grafts, flap surgery, and bone grafts. Maintenance and monitoring. So regular follow-up visits are crucial for maintaining periodontal health after treatment. So this includes professional cleanings, oral hygiene instruction, and monitoring for any signs of disease recurrence. Innovative therapies for periodontal care. Advancements in dental technology and research have led to the development of innovative therapies that enhance periodontal care for the older adults. These therapies offer a range of benefits from improving treatment outcomes to enhancing patient comfort. So these advancements allow for a personalized approach catering to the specific needs of geriatric patients. Laser therapy. So laser therapy uses a focused beam of light to remove bacteria and stimulate the tissue regeneration. It offers a precise and minimally invasive approach, reducing pain and discomfort. Guided tissue regeneration. So it involves using a membrane to promote bone and tissue regeneration in areas of periodontal bone loss. Stem cell therapy. It harnesses the regenerative potential of the stem cells to promote the healing and tissue repair in the periodontal defects. Antimicrobial photodynamic therapy. It combines a photosensitizing agent and a specific wavelength of light to target and kill bacteria in the periodontal package. So this technique helped to reduce the inflammation and improve the periodontal health. So importance of the interdisciplinary collaboration. So achieving optimum periodontal health for geriatric patients often requires a multidisciplinary approach involving the dental professionals, physicians and other healthcare providers. So this collaboration allows holistic understanding of the patient health and ensures that oral healthcare plan is integrated with the overall health needs. So this comprehensive approach leads to more effective treatment outcomes, improved patient satisfaction and better overall quality of life for the older adults. So the benefits of the patients are improved treatment outcomes, reduce the risk of complications, better management of chronic diseases, enhanced patient comfort and satisfaction. Benefits for the healthcare team is the enhanced communication and coordination, improved patient education and support, more efficient use of resource, access to a wider range of expertise. Patient education and empowerment. Empowering geriatric patients to take an active role in their oral health is crucial for maintaining a long-term well-being. By providing clear and comprehensive information, fostering open communication, and building trust, dental professionals can empower older adults to make informed decisions about their oral health care. So this proactive approach is essential for promoting a healthy smile and improving the overall quality of life for the older adults. So, we can educate the patients by instructing the oral hygiene, by open communication, understanding the systemic health, and providing information about the local community resources. So, ensuring long-term oral health for the elderly. A proactive and comprehensive approach is essential to maintain oral health throughout the aging process. By incorporating preventive measures, addressing the specific needs, and promoting the ongoing care, individuals can enjoy a lifetime of healthy smiles. So, by visiting regular dental checkups, routine dental visits are very crucial for detecting early signs of periodontal disease and other oral health issues. And personalized oral hygiene instruction, providing tailored guidance on proper brushing, flossing, and oral hygiene techniques, considering the individual's limitations and needs, is crucial for effective self care. Interdisciplinary collaboration. Working closely with the physicians and other healthcare providers ensures a holistic understanding of the patient's health and facilitates an integrated care plans that addresses all aspects of the well-being. Continuous monitoring and maintenance. Regular follow-up visits for professional cleanings, assessments and adjustments are vital for maintaining optimum oral health and preventing the disease recurrence. So thank you. So here ends my slide and thank you for a great opportunity to get participated in this. Thank you. Thank you everyone.
Good morning, everyone. Today we will be discussing a pervasive yet often overlooked condition in older adults, xerostomia or dry mouth, and discussing few novel approaches to managing xerostomia in geriatric dentistry. I'll be covering it under the contents: introduction to xerostomia, causes of xerostomia, effects of xerostomia, traditional treatment options, non-pharmacological treatments, introduction to TENS therapy, challenges in xerostomia management in older patients, practical considerations for TENS and clinical setup, salivary reservoirs, conclusion, and references. So xerostomia is a condition where the salivary glands in the mouth don't make enough saliva to keep your mouth wet, and it affects about 1 in 5 people, commonly seen in older individuals, and leads to difficulty in speaking, chewing, increases the risk of tooth decay and oral infections. So the few causes of xerostomia are medications like antidepressants, antihistamines, and pain medications, radiation therapy, and few systemic disorders like Sjogren's syndrome, diabetes, and Alzheimer's. So all of this contributes to dry mouth or xerostomia, which causes increase in the pathogenic bacteria in the pathogenic biofilm, which causes oral lesions and dental caries. So few common medication which causes xerostomia are antihypertensives like amlodipine, losartan, antidiabetics like metformin, cholesterol-lowering drugs like atorvastatin, painkillers like paracetamol, cognitive enhancers like donazepam, etc., and xerostomia-inducing drugs like antidepressants, antihistamines, etc. So few effects of xerostomia are extreme dryness and discomfort, upper digestive tract disorders, infectious disease, oral malodor, difficulty in speaking, difficulty in eating, impaired taste, dental caries, periodontal diseases, and sore tongue.
So this is a picture which shows hyposalivation in patient causing dry mucosa and chronic ulceration. The second picture depicting oral candidiasis in xerostomach patients, and the third one showing extensive demineralization and cavitation of teeth in patient with hyposalivation. Few other pictures showing sore depapillated tongue, fissured tongue, angular cheilitis. Now let's discuss few treatment options. Managing xerostomia involves both pharmacological and non-pharmacological approaches. Topical agents like artificial saliva and lozenges can stimulate the salivary glands, which can help alleviate symptoms. However, these solutions are often temporary and require frequent application. Prescription medications like pilocarpine may be prescribed to stimulate saliva production, though these may come with side effects. Few non-pharmacological treatments are acupuncture, low laser therapy, and then we have electrostimulation, that is TENS, transcutaneous electrical nerve stimulation, which has been explored as a non-invasive treatment option. Then few self-management done by the patient could be hydration, chewing a sugar-free gum to stimulate saliva, using a humidifier, especially during the night, few dietary adjustments like soft, moist food and avoiding spicy or acidic food, and using few dental products like mouthwashes, saliva substitutes, and also avoiding alcohol-based products.
To continue, the introduction to TENS therapy, which is a non-pharmacological approach to the treatment of xerostomia. So TENS, transcutaneous electrical nerve stimulation, is a device that uses electrical impulses to stimulate the nerves, and it has shown a promising advancement in the treatment of xerostomia in older patients, and it is non-invasive and well tolerated. However, TENS therapy has been also used priorly in the treatment of pain relief medications for endometritis, arthritis, and in the head and neck region in the treatment of temporomandibular joint disorders for orofacial pain. There was a study done recently by Ramados et al., in which they focused on patients above 60 years of age with xerostomia, and they custom designed a TENS device which evaluated the effects on salivary pH, cortisol levels, antioxidants, and microbial balance, showing a significant improvement in the saliva quality and output after 3 months of therapy. So this is a device which has been designed by them, and it is a headphone-like device which has 2 electrodes on right and left side with a whole ear positioning guide, which is placed into the extraauricular meatus, and this device is positioned over the skin above the parotid gland, which releases electrical impulses triggering through the device to postulate the nerve, auriculotemporal nerve. The afferent nerve fibers carries impulses to the salivary gland nuclei in the medulla oblongata, which in turn directs the signals to the efferent part of the reflex, leading to salivary stimulation, causing improved salivary flow. So the mechanism of TENS, as already explained, is it stimulates the nerve pathways, that is the glossopharyngeal, facial, trigeminal, and auriculotemporal, leading to the boost of the postganglionic efferent nerve activity in salivary gland, improving the secretomotor drive and enhancing the salivary output. So comparing the traditional and TENS-based treatments, there are salivary substitutes which provide temporary relief but are required infrequent reapplication, and other pharmacological treatments tend to produce various side effects, including increased sweating and urinary issues in the elderly. However, TENS provides a longer increase in the salivary output with minimal side effects. So some challenges in xerostomia management in older patients include medication compliances, as they are already under a lot of medications. They may have issues with the pharmacological treatment of xerostomia as well, and also the side effects may not be ideal for all the patients. Coming to comorbidities, geriatric patients often have other health conditions complicating the treatment, and so for that reason, patients with xerostomia who have electrical pacemakers and other cochlear implants or auditory devices cannot be included for this kind of therapy. But the TENS in the clinical setting could be a practical consideration as it is cost effective, easier to use as it is a compact device as shown in the picture, and allows monitoring for the salivary, allows a clinician and the patient to monitor the salivary output and the patient comfort during use. So coming to another treatment option, that is the salivary reservoir denture. It is to overcome the problem in patients with xerostomia, various techniques such as the incorporation of salivary reservoirs with holes in the maxillary or mandibular dentures, or both of it has been incorporated to ensure consistent flow of salivary substitute in the oral cavity, which moves to keep the oral cavity moist during the entire treatment. So, a salivary reservoir is an intraoral device that is incorporated into a removable processes in order to allow a continuous release of salivary substitute into the oral cavity over a prolonged period of time to maintain the ecological balance of the oral cavity. So the average volume of salivary reservoir ranges from about 2.3 to 5.3 milliliters, and it allows a duration of flow range from 2 to 5 hours. So these were the treatment modalities that we could provide as a dentist to geriatric patients with xerostomia. So to conclude, xerostomia is a complex condition that requires a multifaceted approach, particularly in the elderly patients. While pharmacological treatments can provide short-term responses, newer non-pharmacological options like TENS and reservoir dentures are offering more sustainable and comfortable solutions. As the population ages, it is essential that we continue researching and developing innovative treatments for xerostomia to enhance the quality of life for geriatric patients. These are our references. Thank you.
Good morning, everyone. The topic of my presentation is prosthodontic rehabilitation of a completely edentulous patient with abnormal jaw lesion. A condition where mandibular arch is more prominent than the maxillary arch, leading to reverse occlusion or edge-to-edge bite. This is commonly associated with skeletal class 3 relationship. The challenges faced in prosthodontics are difficulty in achieving functional and aesthetic occlusion, increased complexity in managing denture stability and facial aesthetics. 62 years old female patient reported to the department with a chief complaint of difficulty in chewing and dissatisfaction with his old denture. History of completely edentulation for 10 years with ill-fitting denture that causing discomfort. On extraoral examination, a concave facial profile was observed, that is classical for class 3 relationship. On intraoral examination, maxillary arch showed moderate resorption in anterior region, well formed posteriorly, and mandibular arch shows pronounced resorption in posterior region with prominent anterior ridge. These are the intraoral, maxillary, and mandibular arch views. Diagnosis for this condition are completely edentulism of both maxillary and mandibular ridge with class 3 ridge relation. That objective of the treatment to restore the functional occlusion for improving chewing efficiency, achieve an aesthetic outcome with proper lip support and smile line. The treatment plan was fabrication of new maxillary and mandibular complete denture with bilateral balanced occlusion to accommodate the class 3 relation. Started with the clinical procedures. Primary impression was made with compound impression. This figure shows the primary maxillary and mandibular impression, followed by this figure shows the primary maxillary and mandibular cast. Secondary impression was made with polyvinyl silicone impression materials. This figure shows secondary maxillary and mandibular primary impression, and this figure shows secondary maxillary and mandibular cast. Recording jaw lesion, the patient presented with a collapsed vertical dimension. This evident through over-closure of jaws, poor lip support, and aged facial appearance. Adjustments are made incrementally until the ideal height is achieved, allowing space for proper lip support, phonetics, comfortable closing without straining of muscles of mastication. Started with the teeth arrangement. Arrangement of the anterior teeth. Anterior teeth are arranged in edge-to-edge relation. This edge-to-edge procedure on anterior teeth that has stability on both maxillary and mandibular denture. This figure shows the teeth arrangement of posterior teeth. Lower arch is more wider than the upper arch. The crest of the lower ridge is buccal to the upper ridge. That is difficulty in placing normal occlusion. In this situation, the teeth are placed in cross-bite condition. The teeth are made interchange in arch. Right upper teeth are placed in left lower region. Left upper teeth are placed in right lower region, vice versa. This upper arch is already small, so that the first premolar was removed to maintain the intercuspal relationship. These images show the teeth arrangement of maxillary and mandibular arch. This figure shows completed teeth setting of maxillary and mandibular arch. After the teeth setting was completed, the denture was fabricated. That the final denture is inserted. Occlusion was checked. Immediate evaluation of comfort and aesthetics. Minor adjustments are made to relieve any pressure areas. Follow up for then after 1 week to ensure long-term comfort and function. These are the pre and post rehabilitative view of the patient. Treatment outcome that restored stable occlusion with proper centric relation, improved chewing efficiency and comfort during function, improved lip support, proper smile line that correcting the concave profile. Patient reported high satisfaction with the aesthetic comfort and function of the denture. Significant improvement in quality of life due to enhanced chewing ability and overall appearance. Conclusion. One of the main challenges in treating patients with class 3 ridge lesion is managing the occlusal discrepancy caused by the prominent mandibular arch and retrusive maxillary arch. Traditional denture fabrication techniques that work well in class 1 arch or class 2 relationship, that is less effective here. Therefore, that more attention is there to for jarlation records and arrangement of artificial teeth. That is critical to ensure comfort and function. These are my references. Thank you.
Good morning. I am presenting the PPT on Aging Smiles, Comprehensive Oral Health Care for Elderly. Here we are discussing about the various aspects of elderly people, how they will have their teeth and their periodontal status. So how we are supposed to manage that. So we will be dealing with that. So why it is important for us to know about the oral health in aging. So this will help to prevent the dental issues. Then it will help in support the nutrition, boost confidence, and reduces pain. So, in order to have the at a elderly people, they will suffer from various nutritional deficiency. So we have to boost the confidence in them by providing the proper nutrition and also to reduce the pain. So we also know that there is an impact on the quality of the life of the patient. So there are various studies like oral and systemic links are present in which there is a decrease in the oral health will lead to the increase in the heart disease, strokes, mouth cancer, diabetics, and this will lead to the increase in the gum disease, tooth loss, bad breath, and dental decay. And the quality of the life of the patient also will be decreased due to the insufficiency of the nutritional deficiency. The longevity also will be decreased. So, the connection between the oral health and the systemic health underlines the need for the comprehensive dental care for the elderly to enhance the overall quality of life. The elderly segment of the population is broadly divided into three stages, that is 65 to 74 years. They are the new or the young elderly who tend to relatively be healthy and active. And the people at the age of 75 to 84, they are old or a mid to old, who vary from being healthy and active to those managing an array of the chronic diseases. And the age of 85 years and above, they are the oldest and old, and they're the last group where there is a fast growing segment of this group. But Nowadays, there is a sudden blast of 65 plus population in the last decade. And India also there is no acceptations for that. We see many elderly people in our country too. So the geriatric and the patient complex will overlap. For example, it is a socio-economic status and oral issues, physiological or psychological, and pharmacological and medical issues. Socio-economical status, where we see due to the decrease in the increase in the population, there is a decrease in the work productivity as well as the oral issues, where we see a more commonly the vitamin deficiency and increase in the root caries, xerostomia, and psychological and pharmacological, where there is an increase in the medicines intake. This will leads to the xerostomia, and they are all interconnected. And what are the objectives of the geriatric dental care? To recognize and relieve the oral health issues, then restoration and preventions of the function to maintain the ideal health and functions of mastication. So, what are the age related oral health changes? We see decreased salivary flow, that is xerostomia, wear and tear of the teeth, attrition, abrasion, gum recession, tooth discoloration, where there will be an increase in the deposition of the dentine, and secondary dentine formation will be there, that will lead to the tooth discoloration. We see more yellowish color, and then increased risk of the oral infection due to the reduced salivary flow, and also the increased medicines intake. And the dental caries, we see more commonly the root caries, where there will be a recession. What are the nutritional challenges we see in the older age group? In the older age group, we see there will be a difficulty in the chewing because of a dry mouth, that is increase of xerostomia, poor nutritional intake, and oral health implications include the soft diet, deficiency, risk of and malnutrition. What is the takeaway home message? Promoting the good nutrition is a vital for maintaining oral health in elderly patients, ensuring their diet support both general and oral well-being. So changes that we see in the salivary gland and secretion with the ages, age-related changes in the salivary gland, we see a decreased gland function, atrophy, impact of medications. And what are the effects of reduced saliva? Xerostomia, increased risk of oral issues, and impaired digestion. So basically, saliva is important for the chewing as well as to swallow. If saliva is decreased, then there will be a impaired digestion. Takeaway home messages: aging and medications use can significantly reduce the salivary secretion, leading to oral and health complication and decreased quality of life in elderly individuals. 8 changes in the oral mucous membrane. The structural changes, we see thinning of the oral epithelium, reduced elasticity, atrophy of minor salivary glands, and slower healing are the functional changes we see: increased sensitivity and irritation, reduced immune function. What are the care implications that we are supposed to take care is require the gentle oral care. We have to use a soft bristle brush and regular hydration using them, and also moisturizing to prevent the complications, to prevent the secondary infections. Then what are the age related changes in the teeth? The structural changes, we see the enamel wear, and that will leads to the dentine exposure, and there will be chances for the color change because of the secondary or the tertiary dentine deposition. And the functional change, we see the pulpal canal will be shrink, and there will be a difficulty in doing the root canal treatment if it is involvement of the pulp is there, and reduced regenerative ability and increased brittleness. So what are the oral health implications? They are the higher risk of the decay. Because of the gingival recession, we see a root caries and fracture are the more common in the older adults. Where a tear on the restoration, older fillings, crowns, or the bridges, they have to be replaced. Prosthetic need, tooth loss, or the damage may require dentures or implant. So, aging in the periodontal disease, what are the age-related periodontal changes? We see a gum recession, bone loss, decreased tissues, and regeneration. So, what are the increased risk factor? Chronic inflammation, weakened immune response, systemic health links. As we have told that there is a systemic health link. When there is an increase in the infection, there are chances for more of the heart problems, respiratory problems. Then what are the oral health implications? Increased risk of the tooth loss. There's a progressive bone and the tissue loss can lead to the tooth mobility or the loss. Chronic periodontitis, more severe and frequent in older adults, requiring ongoing management. Impact on the quality of the life, difficulty chewing, discomfort, and aesthetic concern. Coming to the conclusion of this presentation, aging affects all aspects of our oral health, from teeth and gums to salivary glands and oral mucosa. Age-related changes increase the risk of dental problems. Importance of preventive care, regular dental checkup, good oral hygiene and tailored care can prevent or manage the age-related oral issues. Holistic approach, oral health is closely linked to the systemic health, highlighted the need for the integrated care that consider both dental and overall health in the elderly patient, enhancing quality of life by addressing the oral health challenges. We can improve nutrition, comfort, social interaction, and overall well-being in the elderly. Thank you so much for your patience.
Topic of my presentation is incorporation of artificial intelligence in geriatric dental care. To begin with the intro, as a result of improvements in living standards, advancements in medical technologies, and improved accessibility to medical and dental care, life expectancy of people is on rise. The ratio of older people in the world is expected to increase from 0.7 billion in 2019 to 1.5 billion in 2050. Unfortunately, the dental condition of many older adults is poor due to worsened physical conditions and cumulative damage caused by dental diseases in the past. Healthy aging is defined as the process of developing and maintaining the functional ability that enables well-being at older age. The WHO emphasizes that being free of disease or infirmity is not a requirement for healthy aging, as many older adults have one or more health conditions that have little influence on their well-being when they are well controlled. Apart from aesthetics, the main function of dentition is investigatory. Hence, in dentistry, healthy aging can be achieved by the control of dental diseases and the maintenance of masticatory portion. This comprehensive overview explores the multifaceted role of artificial intelligence in dentistry, delving into its applications in diagnostic imaging, caries detection, periodontal disease assessment, treatment planning, patient engagement through virtual simulations, and operational efficiency. So the few key ways that AI is making an impact is predictive analytics for oral health, which is AI-driven predictive models which can assess the risk of common geriatric dental issues such as the periodontal disease, tooth loss, and oral cancer. By analyzing historical patient data, AI can help dentists predict future complications and prioritize preventive measures. In the second part, the personalized treatment plans, the AI tools can analyze vast amounts of patient data, for example, dental history, medical conditions, medications, to recommend personalized treatment strategies for elderly patients who often present with complex health profiles. AI ensures that dental treatments align with the patient's overall health, minimizing risks associated with age-related vulnerability.
Scope in various fields. With the advent of teledentistry, AI-powered diagnostic tools delivered via mobile apps using machine learning algorithms can aid in early detection and prompt necessary interventions towards oral diseases in older adults, thus mitigating the risk of systemic conditions linked to poor health.
Oral hygiene assistants and AI-based devices can assist elderly patients with oral hygiene, especially those with limited dexterity or cognitive impairments. Smart toothbrushes with AI integration can provide feedback on brushing techniques or suggest corrective actions in real time. AI technologies have also been harnessed in the realm of prosthesis design and manufacturing, offering a substantial regimen for oral function rehabilitation in older adults. For instance, software applications employing generative adversarial network have shown promise in automating the design and manufacturing processes of dental prostheses, thus accelerating the restoration of oral functions in geriatric population. Diagnostic assistants, AI-powered imaging systems, use machine learning models can enhance diagnostic accuracy by identifying early signs of dental diseases in X-rays, 3D scans, and other imaging technologies. These systems help identify hidden caries, root fractures, or other issues that might be easily missed, especially in older patients with multiple oral health issues. AI is mainly used in lesion segmentation in fields of cardiology and endodontics, identifying tooth surface loss, root caries, periapical lesions, or root fractures is crucial in further treatment decision making. Furthermore, the development of AI systems with fields of oral and maxillofacial surgery is promising. Neural networks may be used to diagnose pathologies in the bone and mucosa, guiding orthodontic surgery, implantology, and complication management. For example, with an accuracy of 94%, a support vector machine classifier system was able to differentiate between periapical cyst and keratocyst odontogenic tumors with CBCT scans. Orthodontic treatment planning, a web-based deep learning application analyzing 23 landmarks on cephalograms, showed a classification success rate of 88.43%. Robotics in dental procedures for geriatric patients, AI-powered robotics can assist in performing delicate dental surgeries or procedures, reducing the margin of error, minimizing discomfort, and ensuring faster recovery. Cognitive health and dental care, AI systems can support dentists in managing patients with dementia or cognitive impairments. By using patient data and behavioral analysis, AI tools can help caregivers create appropriate dental care routines that accommodate cognitive decline. Dental care for older adults, AI chatbots or virtual assistants can educate elderly patients and their caregivers about proper oral hygiene, dietary choices, and preventive measures. They can also remind patients about dental appointments or alert caregivers about any deviations from the care routine. The use of AI in geriatric dental care is still growing, and the use of technology evolves. It is expected to further enhance precision, accessibility, and preventive care for aging populations.
Coming to the drawbacks of using AI in dentistry, the top three disadvantages cited by patients regarding the use of AI in dentistry were the impact on workforce lives, the new challenges to the fiduciary relationship between the dentist and the patient, and third is increased dental care costs. Additionally expressed disadvantages were liability, neglect of education, limited applicability for older dentists, and lack of empathy. So to conclude with this, we talk upon the dental care for the older adults, which requires special attention to their physical and medical conditions. Although older adults are at risk of oral diseases, most of these diseases are preventable. Hence, prevention and early treatment are important. To achieve healthy aging, dental treatment approaches should be simple and prevention focused, with an aim to stop oral diseases from progressing and restore masticated function with teeth replacement. These are my references. Thank you all.
Good afternoon, everyone. The topic for my presentation is full mouth rehabilitation of a completely edentulous patient using an implant-supported hybrid prosthesis, a case report. Introduction. One of the greatest challenges in dentistry is the treatment of patients with severely atrophic jaws, which can be horizontal or vertical or both. Even if sufficient vertical bone is present, lack of ridge width can still preclude treatment with implants. In few patients, implant-supported prosthesis treatment is almost impossible without complex techniques such as nerve transposition and grafting. The all-on-6 treatment concept was developed to maximize the use of available remaining bone in jaws, allow immediate function, reduce cantilever extensions, and avoid regenerative procedures that increase the treatment cost and morbidity as well as the complications inherent to these procedures. Case history: a 60-year-old male patient reported to the Department of Prosthodontics with a chief complaint of missing teeth in the lower arch following removal of a positive prosthesis in the mandibular arch. Patient was a maxillary complete denture wearer for past 2 years and was satisfied with the same. He wanted a fixed replacement of the remaining teeth. Intraoral examination revealed high, well-rounded, completely edentulous maxillary arch and partially dentulous mandibular arch with periodontally compromised teeth. This is the intraoral maxillary and mandibular view. This is the extraoral frontal view and intraoral frontal view. Treatment options: removable complete denture, flexible complete denture, and implant-supported overdenture were excluded as the patient wanted a fixed treatment. Implant-supported fixed prosthesis was planned, keeping in mind the patient's conditions and economical status. Mandibular rehabilitation. A cone beam computed tomography revealed bone loss with compromised tooth structure in relation to the remaining natural dentition. Dental implant planning was done in 3D constructed data. Impressions of the maxillary and mandibular arches were made and the maxillary arch was scanned. The positioning of the artificial teeth was done according to the natural dentition for the fabrication of the immediate prosthesis. Analysis of occlusion was done before and after the removal of the natural teeth. These are the views of the mandibular prosthesis designed digitally. The prosthesis was milled in PMMA using CAD/CAM technique, and the aesthetics were enhanced through curing of pink gingival composite. This is the preparation of the site on the day of implant surgery, followed by giving the inferior alveolar nerve blocks on both the sides. Extraction of the remaining natural dentition was done. This was followed by reflection of the mucoperiosteum and stabilization of a Marlowe guide for implant placement. Osteotomy was initially initiated with the help of pilot drills under copious irrigation, and the final osteotomy was prepared by using sequential drilling. The parallelism was ensured using paralleling pins. Implants were placed with a final torque of around 35 Newton centimeter, followed by the placement of multi-unit abutments and suturing with the help of trio silk suture. Post-operative OPG was taken to confirm the implant size. Burnout cylinders were obtained after conventional casting, which were supposed to be picked up in the impression. A pickup impression was made to obtain the position for creating holes in the PMMA denture for the incorporation of the burnout cylinders. Burnout cylinders were placed above the multi-unit abutment, and a piece of sterile glove was cut and adapted to act as a blockout spacer. The burnout cylinders were picked up using autopolymerizing acrylic resin in the immediate prosthesis. This is the intraoral mandibular view following the insertion of the prosthesis, intraoral frontal view, and extraoral frontal view. A post-op OPG was taken after 3 months, and this is the gingival emergence profile after the removal of the immediate prosthesis. Primary and the secondary impressions of the maxillary arch was taken for the fabrication of a conventional complete denture, and multi-unit impression copings were placed in situ for the fabrication of a jig. A jig trial was done using autopolymerizing pattern resin, and a pickup impression was made. After that, the implant analogs were placed on the impression, and after the application of gingival mask, a master cast was obtained. A jig was fabricated on the master cast, and its fit was verified inside the oral cavity. Once satisfied with the fit of the jig, the framework was designed digitally. The metal bar was fabricated using the DMLS technique. Its fit was verified intraorally. A jaw relation was recorded, followed by trying and designing of the final prosthesis. This is the final prosthesis, that is the maxillary complete denture, opposing a mandibular implant-supported hybrid prosthesis. These are the right lateral, frontal, and left lateral views after the insertion of the prosthesis. This is the pre-rehabilitative and post-rehabilitative views of the patient. The patient returned to us after 6 months of delivering the mandibular prosthesis and wanted similar prosthesis for the maxillary arch as well. He wanted a fixed treatment. This is the extraoral frontal view and intraoral frontal view. A surgical guide was fabricated by the duplication of the denture the patient was wearing. and composite markers were applied on the surgical guide. The site preparation was done, followed by giving the nerve blocks. The surgical guide was placed intraorally, and access holes were prepared at the future implant sites. Osteotomy preparation was done using the guide. Implants were placed with the help of a torque around 30 to 15 Newton centimeter. A post-op OPG was taken. This is the placement of the multi-unit abutments. The pickup of the implant position was done on the denture for the placement of the burnout cylinders. The burnout cylinders obtained after conventional casting, sterile glove for acting as a spacer. And this is the pickup of the burnout cylinder was done using the autopolymerizing acrylic resin, and this is the immediate prosthesis. This is the post-op OPG after 6 months and gingival emergence profile of the patient after 6 months. Similar to the mandible, multi-unit impression copings were placed, followed by jig fabrication, pickup impression of the jig, then jig verification. This is the digital designing of the metal bar, DMLS fabrication of the metal bar, followed by intraoral trying, recording of the jaw relation, trying, and designing of the final prosthesis. This is the final prosthesis extraorally as well as intraorally. This is the right lateral, frontal, and the left lateral view after the insertion of the maxillary implant supported hybrid prosthesis. This is the pre-rehabilitative and post-rehabilitative extraoral view. Conclusion: various researches done on the concept and practice of the rehabilitation has advanced the all-on-6 treatment option from the skeptical to the predictable with commendable success rates. The long-term results of this technique and the numerous advantages of immediate loading, the reduced morbidity, no added surgery, reduced cantilever extension, and the high patient satisfaction should be taken into account when a decision among the alternative treatment options for an atrophic jaw has to be made. These are my references. Thank you.
A very good morning to one and all gathered here. We are here to present the topic on stopper prosthesis, a digital offer. These are the contents which we are going to see in this presentation. In India, the percentage of geriatric population is gradually increasing. So as dentists, we have the responsibility to provide them a proper, comfortable and non-invasive treatment procedures. So we have an offer from digital technology to provide them precise, easier and faster way to treat the geriatric population. Lifestyle changes, which includes improper food habits and smoking, may cause chronic conditions like diabetes mellitus and carcinoma respectively. Let us go back and switch the time machine to 2020. Yes, we were wearing masks and under the same roof, which was a global pandemic, the COVID. It also created a black hole in everyone's life, which is an epidemic within the pandemic, the fungal disease mucormycosis. With increased age and comorbidities, the risk factor for COVID-19 is increased, so high doses of corticosteroids were given, which causes immunosuppression. This is a well-established risk factor for mucormycosis. This is the global distribution of COVID-19 associated mucormycosis. Our country, India, is shaded with dark blue, which indicates the increased severity of COVID-19 associated mucormycosis cases. The orange shade pie chart indicates the survival and deceased cases. The surgical intervention of these people may cause palatal defect. The palatal defects in the population may result from congenital malformations, trauma, disease, pathologic changes, radiation burns, or surgical intervention. They may cause hypernasal speech, leakage of fluid into the nasal cavity, and impaired masticative function. The definition of obturator is a maxillofacial prosthesis used to close a congenital or acquired tissue opening, primarily of the hard palate and/or contiguous alveolar or soft tissue structures. The phases of prosthetic procedure include surgical obturator prosthesis, which is given immediately after the surgery, interim obturator prosthesis, which is given 4 to 10 days after the surgery, and definitive obturator prosthesis, which is given 4 to 6 months after the surgery.
Here, I'm going to discuss a case report on obturator. This is the patient data. A 52 years old male patient reported to the Department of Prosthodontics with a chief complaint of difficulty in swallowing, which leads to the weight loss of around 6 kgs. He also wants to replace the temporary plate in his upper arch, which he used for the defect caused by the surgical excision of maxilla done for the management of mucormycosis. This is the extraoral examination of the patient. A facial defect was noted, lip fullness is compromised, and the nasolabial fold is obliterated. On intraoral scanning, medial maxillectomy was done on the premaxillary region before 2 years. Patient was rehabilitated with interim prosthesis. As a healing takes place, the interim prosthesis was unstable, which made the patient report to the department. Patient also complains of nasal regurgitation, difficulty in swallowing, and mastication. We also observed a severe gag reflex during conventional impression. Intraoral scanning was made as an alternative option. This is the intraoral scanning of the mandible. On radiographic examination, a radiolucency was noted on the maxillary region, which made the oroantral communication more evident. Coming to the treatment plan, we advise the patient to rehabilitate with a definitive maxillary obturator. Here we are going to discuss a technique which combines the intraoral scanner to fabricate a millet record base and the conventional technique to fabricate a definitive maxillary prosthesis. Here we use Merit I700 intraoral scanner to scan the intraoral image and extraoral images. This is how the scanning was made. Using an intraoral scanner, the maxillary arch was scanned. The scanning was done both intraorally and extraorally. After the scanning, the images were obtained as the STL files, that is standard tessellation language files. This is the intraoral scanning of the maxilla, and this is the extraoral scanning of the patient, and this is the mandibular intraoral scanning. These STL files were exported to the Exocad software, where we designed a definitive maxillary prosthesis. By using an Exocad software, 3D printed denture base was obtained. This is the Intaligo surface of the denture base, and this is the Cameo surface of the denture base. This denture base was inserted into the patient's mouth and checked the fit of the denture. By asking the patient to say ha, we check the fit of the denture. After checking the fit of the denture, the face bow transfer was made. The maxillary occlusal rim was fabricated and the vertical dimension was determined and the central relation was completed and the face bow was made. And the wax tail was done in the patient. This is the right lateral view, front view, and left lateral view. To reduce the weight of the prosthesis, a wax spacer was given. To reduce the weight of the prosthesis, a halo denture was planned and the wax spacer was also used in this prosthesis. The packing was done using a conventional processing. Using a mini steam jet, the wax was removed. The floating denture makes the halo region more evident. This is the definitive obturator we obtained. The definitive obturator was relined with a permanent relining material to improve the retention of the denture. After the denture incision, this is the right lateral view, front view, and left lateral view. Front view, pre-op and post-op. Lateral view, pre-op and post-op. Coming to the conclusion, nowadays most of the geriatric patients are moving towards modernization. Advances in the digital health technology has opened the new frontiers for reaching the goals. These are our reference. Thank you.
Hello everyone, my today's topic of presentation is periodontal changes and challenges faced by the elderly population. In this pie diagram, we can see the prevalence of various periodontal diseases in elderly patient. The most common disease which can be seen in elderly patient is the generalized periodontitis, which represents 34.8% of the conditions. And the least common which can be seen is the periodontal health, which represents only 2.5% of the conditions. So the key changes which can be seen in elderly population is the tissue degeneration. This occurs due to reduced collagen production and slower healing, which can be seen in elderly population. This leads to decreased elasticity and resilience of the gingiva, leading to receding gums and greater exposure of the tooth roots. Bone loss. Gradual alveolar bone loss is common in elderly, which leads to weakening of the structural support of the teeth, making them prone to mobility and the tooth loss. Decreased immune response. Aging affects the immune system's ability to fight infection. This leads to reduced capacity to combat oral pathogens and increased chances of inflammation. Diminished salivary flow or the xerostomia or the dry mouth is a condition which can be age-related or also due to side effects of various medications. This leads to reduced natural cleansing action of saliva and increased plaque accumulation, leading to increased periodontal disease risk. Systemic health and its influence of periodontal health. The aging population is often affected by chronic diseases and health conditions that further challenge the periodontal health. The most common systemic condition that affect periodontal health is the diabetes. Diabetes, which is a common in older adults, this impairs the body's ability to regulate inflammation and healing process, which exaggerate the periodontal disease. The poor glycemic control, it can also accelerate the tissue breakdown. Cardiovascular diseases is a form of inflammation, systemic inflammation. And periodontal inflammation, this also contributes to systemic inflammation, which can worsen the cardiovascular conditions like the arteriosclerosis. Osteoporosis or the reduced bone density, which can be seen in elderly population, this does not only affect the skeletal health, but it also weakens the alveolar bone, leading to increased risk of tooth mobility and tooth loss. Respiratory infections are common in bacteria from the periodontal pocket or the biofilm. It can get aspirated into the lungs, leading to respiratory diseases such as pneumonia, particularly in bedridden elderly patients. So the problems which can be seen with aging is the anatomical, physiological, and morphological factors, the plaque control, post-response immune function, systemic and various psychological problems and diseases. The medication which the patient has been taken also impact the periodontal diseases. Structural changes which are seen with aging is the loss of alveolar bone and changes in the gum tissue, and the physiological changes which can be seen is the decreased salivary production and altered immune response. The dry mouth, which can be seen in elderly, which is a very common condition, it can hamper or it can impact the taste perception. Also, it can lead to increased prevalence of dental caries, oral malodor, and difficulty in speaking. So common periodontal changes which can be seen with the aging is the gingivitis. Gingivitis, this is an inflammation of the gums and the symptoms involves the redness of the gingiva, swelling and bleeding of the gums. Periodontitis, this is an advanced form of gum disease. The symptoms include the deeper pockets and bone loss which leads to tooth mobility and tooth loss. Risk factor in the elderly. So there are various risk factors like the systemic there are various systemic diseases which are present in the elderly population which act as a periodontal risk factor. These are the diabetes, heart diseases, the medication the patient which has been taken, and the lifestyle factors like the nutrition, tobacco use, and oral hygiene practices. So periodontal diseases. How the periodontal disease they impact the systemic conditions. In this diagram, we can see this is the periodontal biofilm or the dental biofilm. The bacteria which is present in this biofilm and their toxins, they get disseminated into the bloodstream and causing to various systemic responses. The microbial and inflammatory challenge, this triggers the hepatic response, leading to release of acute phase proteins from the liver. And these acute phase proteins They may promote oxidized low density lipophosphatase accumulation and arterial plaque formation. This further leads to increased chances of MI and stroke, and also it can lead to various complications of pregnancy. So these are the this diagram shows the periodontal disease and having its impact on various systemic conditions. So the challenges faced by elderly is the most common is access to dental care. It can be due to financial barrier or the transportation issues, cognitive decline. It can be due to it has impact on personal hygiene and self-care, physical limitation, difficulty in maintaining the oral hygiene routines. So how we can prevent or manage these conditions? We can do it by regular dental checkups. Oral hygiene practices like the proper brushing and flossing techniques can be given to the patients and dietary considerations. So what is the role of caregiver? Caregivers, we can train them to assist with dental care, also encourage and educate the patient, raising the awareness about their oral health importance. So in conclusion, we can say that there is importance of addressing the periodontal health in elderly, which needs a multidisciplinary approach to care. Thank you.
Presentation is comparison of shear bond strength for one-step self-etch versus universal adhesives and contaminated and decontaminated dentin surfaces and in vitro study. Introduction. Since years, adhesion to tooth structure has been a challenging concept. The dentinal adhesives have shown a considerable improvement and development through years. One of the most important factors for ensuring adhesion of composite resin to dentin is isolation. Contamination encountered during bonding procedures can weaken bond between composite and tooth. Moisture such as gingival fluid, blood, saliva can have a negative impact on bond's integrity, causing micro leakage at tooth restoration junction. That could lead to loss of restoration, recurrent caries, post-operative sensitivity, and discoloration of the restoration. Need for the study. The contaminants such as saliva, blood has been shown to reduce the bond strength between composite and dentin. As simplified adhesives are widely used nowadays, decontamination of contaminated dentin will restore the bond strength. Hence, this study was designed to evaluate the effect of different surface contaminants like saliva and blood and their decontamination with ethanol on the shear bond strength of one-step self-etch adhesives versus universal adhesives to dentin. This in vitro study aims to evaluate the effect of various surface contaminants and decontamination with ethanol on the shear bond strength between one-step self-etch and universal adhesives to dentin. Materials and methodology. Maxillary and mandibular molars with intact clinical crowns, sufficiently wide occlusal table, and which are extracted for periodontal reasons were included, whereas exclusion criteria, teeth which are decayed, discolored, restored, and with developmental anomalies with severe attrition, abrasion, erosion were excluded. These are my materials, 70 extracted tooth, human saliva, blood and ethanol, universal bonding agent, one-step self-etch adhesive, high viscosity composite resin. A total of 70 extracted molars were included and stored in 0.1% thymol solution. All the 70 specimens were embedded in the self-cure acrylic resin up to 2 mm below the cemento-enamel junction. The coronal buccal surfaces of 70 human molars were ground to expose dentin. The specimens were randomly divided into two groups. Group 1, one-step self-etch adhesive. Group 2, universal adhesives. Both the groups were applied with respect to bonding agent according to manufacturer instructions and were light cured for 20 seconds. Then these two groups were further subdivided into 5 subgroups. Subgroup A was control, where the contamination or decontamination was not carried out. Subgroup B is saliva contaminated. Subgroup C is blood contaminated. Subgroup D is saliva followed by decontamination with ethanol, whereas subgroup E is blood followed by decontamination with ethanol. In subgroup A, control, the respective adhesives was applied and light cured for 20 seconds, whereas in subgroup B, saliva contaminated, respective adhesive was applied and light cured for 20 seconds, followed by teeth which were contaminated with human saliva. Subgroup C, respective adhesive was applied and light cured for 20 seconds, followed by teeth were contaminated with freshly drawn blood. Subgroup D, saliva contamination followed by decontamination with ethanol. Respective adhesive was applied and light cured. Then the teeth were contaminated with saliva, followed by decontamination with ethanol for 20 seconds. Then again, respective adhesive was applied and cured for 20 seconds. Whereas in subgroup E, instead of saliva, the blood contamination was done, followed by decontamination, and again the respective adhesive was applied and cured. In all the groups, a plastic tube of dimension 3 into 3 mm was loaded with composite resin and was placed over the dentin surface and light cured for 40 seconds. The shear bond strength at dentin composite interface was calculated using a universal testing machine. Then the data was subjected to statistical analysis, which included one-way ANOVA, two-case post-hoc test, and independent t-test. Results: one-way ANOVA in one-step sulfate adhesive shows statistically significant difference among all the subgroups, whereas the control group showed the highest bond strength and the blood showed the least bond strength, followed by the saliva. And when both the saliva and blood contaminated groups, when subjected to decontamination with ethanol, there was a raise in the bond strength. This is a universal adhesive. One-way ANOVA showed statistically significant differences among all the subgroups. Here also, the same pattern was observed. The control group showed highest, blood showed least, followed by the saliva. And when the decontamination was done in saliva and blood contaminated groups, the bond strength raised. So here, when we compare between one-step sulfate and universal adhesive showed a better bond strength in all the subgroups compared to one-step sulfate adhesives, but there was no statistically significant difference when subjected to independent t-test. Discussion: in present study, both one-step and universal adhesive contamination with saliva and blood decreased the bond strength. In saliva group, there was a decrease in bond strength because the saliva consists mainly of water, macromolecules, electrolytes, salivary glycoproteins. The water present in the saliva as well as the salivary glycoproteins has been pointed out as a main factor for the reduction of the adhesion to dentin. The reason can be explained by the physical barrier caused by the impregnation of salivary glycoproteins in the adhesive layer, which is poorly polymerized due to inhibition by oxygen. The contaminated layer acts as a semi-permeable membrane after polymerization, which causes decrease in bond strength. In both one-step and universal adhesive, contamination with the blood showed the least bond strength in all compared to all the subgroups. It could be because it creates a greater mechanical barrier than saliva owing to the difference in the type and amount of inorganic and organic elements in the blood. Blood constitutes a heavier macromolecules such as platelets and fibrinogen, which might have occluded the dentinal tubules and lead to shallow resin tube formation. Another reason for the more reduction would be blood contaminants after adhesive curing could interfere with the co-polymerization by forming a barrier between the adhesive and the restrictive material in both one-step and universal adhesive groups. When decontamination was done with ethanol following contamination with the blood and saliva, the shear bond strength to dentin increased in both the groups. Ethanol reduces the surface tension of water present in the saliva and allows the spreading of the mixture along the surfaces that are coated with water. This could be the reason for improved bond strength after using ethanol as a decontaminant. However, the effect of ethanol decontamination following contamination with blood also increased the bond strength in both the groups. The probable reason would be ethanol displaces the barrier produced by blood and prevent collapse of matrices and maintain interfibrillar spaces and favors hydrophobic material embedment. So I would like to conclude that the shear bond strength of one-step sulfates and universal adhesives to dentin is significantly higher in control group without any contamination. Blood contamination showed lower shear bond strength to dentin in both groups compared to saliva. When decontamination was done with ethanol following contamination with blood and saliva, the shear bond strength to dentin increased in both the groups. Comparatively, universal adhesive showed better bond strength than one-step sulfate adhesive in all the subgroups, but the difference was not statistically not significant. These are my references. Thank you.
Hello everyone. Today I'll be presenting on evaluating the oral health awareness and its influence on the systemic health in the geriatric patients and implications for overall well-being. Coming on to the introduction, as we all know, aging is a natural process leading to various systemic health issues, with the oral health becoming increasingly important for the elderly. Poor oral health can significantly impact systemic health, leading to higher mortality rates, reduced quality of life, and increased healthcare costs. With the advancements in the medicine and greater awareness of healthy aging, human lifespans has increased, making oral health essential for overall well-being. Older individuals are more vulnerable to oral health problems that affects their systemic health. Awareness of the connection between the oral health and the systemic health is crucial for the geriatric patients as it can encourage the proactive care, improving both oral health as well as the overall well-being of the patient. On this note, a study was planned and the aims and objective of the study was to assess the oral health literacy, oral health status and quality of life among the geriatric patients and to assess the awareness of the association between the systemic health and the oral health among the geriatric patients. Coming on to the methodology, after obtaining the institutional ethical clearance, questionnaires were prepared and validated, and it was translated to the local language. And it's a cross-sectional study in a tertiary healthcare center. Sample size was planned to 95 as 2% of the patients visiting for the geriatric medicine in the OPD per year. And sampling size was convenient sampling. And after obtaining the consent form, the patients, according to the inclusion and the exclusion criteria, the patients was chosen. Inclusion criteria is who are willing to be a part of the study and exclusion who are not willing to be a part of the study. Coming on to the objective, how did we obtain the results? The oral health literacy and oral health habits are evaluated by a questionnaire, and oral health status was evaluated by the DMFT index, and presence and absence of the periodontal pocket was observed, and quality of life is evaluated by the geriatric oral health assessment index. And the association between the systemic health and the oral health and the quality of life was evaluated by a questionnaire. These are the consent forms was got signed by the patients before enrolling into the study. And these are the questionnaires which we planned to give it to the patients for filling up. Coming on to the results, the data from the questionnaires and the oral health examination was collected and descriptive analysis was done. Continuous variables were reported with the mean and standard deviation, and categorical data were reported in the frequency and percentage. A normality test was performed. A Pearson's correlation test was done to assess the relationship between the GO-high and the DMFT scores. While an independent t-test was conducted to compare GO-high scores between the patients with the presence and the absence of the periodontal pocket. The knowledge, practice, and awareness. The mean value showed that the knowledge of the oral health among the geriatric patients were fair, and oral hygiene practices was moderate, and there was an awareness of the oral conditions was very low. Only 78.1% were unaware that the dentist care is not only about the treatment but includes prevention as well. And 76.2% patients believed that the scaling might be harmful for the gums. And 74.3% patients did not go for the routine dental checkup. And 39% of the patients gave importance to their teeth as other part of the body, and rest of them did not have any idea about it. And 76% said there was no bleeding on brushing. And coming on to the awareness of the impact of oral health on the systemic health, it was very poor, and 55.2% had a poor awareness of the impact of oral health on the systemic health, and 61% did not even know that some medications which are prescribed for their regular systemic diseases can cause dryness of the mouth and reduce in production of the saliva. And 18.1% had an awareness that the bacteria from the oral cavity can enter the bloodstream and cause infections elsewhere. And 24.8% knew poor oral health could worsen existing systemic disorder, and 29.5% had an awareness of visiting the dentist every 6 months, where it was very, very poorly distributed. Coming on to the geriatric oral health assessment index to evaluate the quality of life, it was very low. 31.4% frequently limited the kind or the amount of the food that they had, and 61% had a denture or a teeth that at least sometimes prevented them from the speaking, and 18% were never happy with the appearance, and 47.6% never felt uncomfortable eating in front of the people because of the problems with their teeth and denture. Oral health status and correlation of the GO-high. The patient had a mean DMFT score of 10.3. Among the patients, 49.5% had a periodontal pocket present. The DMFT was correlated with the GO-high, which showed a weak negative correlation, and the geriatric patients with the higher DMFT showed a poor GO-high score. The GO-high score was also associated with the patients with the pockets and without the pockets. It was observed that there was no significant difference in the GO-high score between the two groups. Coming on to the discussion, Literacy was minimal due to probably unclear perception of the oral care among the geriatric population. And knowledge regarding the dentist care is not only about the treatment but also about the prevention was very poor because nowhere the patients were being updated regarding the oral health. Nonetheless, more than half of the elderly patients agreed that if they can take good care of their teeth by brushing well, they can save their teeth for life. And only 21% of the patients gave importance to the teeth as a part of the other as a part of the body, which is why they might not visit the dentist for regular checkup. And they also exhibited good quality of life, which may include the quality of life we say can include many concepts such as health status, functions, and life conditions, which can be influenced by the culture and the value of the system in which one lives. The correlation of the oral health, that is DMFT, with the quality of life showed a weak correlation, still indicating that oral health is affecting the quality of life. Regarding the awareness of the impact of oral health on the systemic health, only 55.5% of the patient had no awareness of having poor oral health influencing systemic health. To conclude, the study gives the inference that oral health literacy, oral health status being minimal, did not affect the quality of life. The awareness of the association between the oral health and the systemic health was poor. The efforts to maintain the oral health should be encouraged among the older age to improve their quality of life. Further evaluation is required among the larger group. What are the limitations of the study? A convenient sampling method. Who attended a tertiary care center might introduce selection bias to the study as the patients had already approached the healthcare system for a reason. Further, public health studies conducted among the community with a random selection could be able to provide the representative and generalizable results for the assessment of the elderly population. Most of the patients are from the rural area and required assistance in filling the forms, which might be probable bias in answering. Thank you.
Good morning, everyone. Today, we are going to explore a vital topic, the role of dental professionals as part of a multidisciplinary team in the holistic care of geriatric patients. With the aging population rapidly increasing, it is important for us to understand how aging affects oral health and what we as dental professionals can do to improve the quality of life for our elderly patients. Now, here is some data for you. By 2050, 1 in every 5 individuals in India will be an elderly, and this trend is even more pronounced in countries like Japan, China, and Indonesia. As people live longer, it becomes crucial to address the specific challenges that aging brings, particularly in the oral cavity.
As people age, their functional status declines, which can affect their ability to maintain good oral hygiene. This is especially concerning because poor oral health in older adults can lead to more severe systemic health issues. One major concern is xerostomia. Xerostomia is patients complain of dryness in mouth. In this slide, we have some causes of xerostomia shown. Many older adults experience this due to medications, and it can lead to significant oral discomfort, increased risk for caries, and oral diseases like candidiasis. In this slide, we have a flow chart showing that how multiple drugs intake can cause adverse drug reactions, and one of them reactions is xerostomia. And this xerostomia in turn has a implication on the health of older citizens. Another issue is polypharmacy, where older adults are prescribed multiple medications. Some of these medications, including those commonly used in dentistry, can cause adverse drug reactions. These reactions, such as xerostomia and mucosal infections, make it harder for elderly patients to maintain good oral health.
Indeed, polypharmacy can create a complex situation for older patients. Studies show that seniors that have more medications than any other age group, and managing these medications properly is very critical. I speak for myself. My grandfather, the amount of medicines he takes is alarming. Mismanagement can not only affect their systemic health but also their oral health. For example, non-steroidal anti-inflammatory drugs you often used in dental care are among the leading cause of adverse drug reactions, especially in older adults. These reactions increase the rate of hospitalization. As dental professionals, we must collaborate closely with medical professionals to carefully manage the medications that impact both systemic and oral health.
To truly improve the oral health of older adults, we need to make changes both clinically and in policy. Elderly patients often face challenges accessing dental care, whether it's due to physical frailty, cognitive impairments, or financial constraints. We must work towards making dental care more accessible by offering specialized geriatric training to dental professionals, improving portable dental equipment, and developing culturally competent services. By focusing on prevention, regular professional cleanings, oral hygiene education, and the use of preventive dental care products, we can help elderly patients to maintain their oral health and overall well being for a longer period of time.
Now, coming to our main topic, why do we need a multidisciplinary approach? Given the complex health needs of older adults, dental care cannot be provided in isolation. A multidisciplinary approach is absolutely essential. Working alongside doctors, nurses, social workers, pharmacists, and family members, one ensures that all the measures are taken to address all the factors affecting the senior citizen's health. For instance, a nursing home resident may need team effort to manage oral care. And how? Medication adjustment by physician, daily oral health care by nurses, transportation by a social worker. The dentist coordinates all these, ensuring that all the aspects of the patient health, oral as well as systemic, are covered comprehensively.
The oral systemic health connection. Oral health is deeply connected to overall health. As Dr. David Satcher, the 16th US Surgeon General, once said, the mouth is a mirror of the body. Oral diseases such as periodontal diseases are not confined to the mouth. In fact, they have been linked to systemic conditions like diabetes, heart diseases, and even strokes. For example, the bacteria from periodontal infections can travel through the bloodstream, affecting other parts of the body. Additionally, conditions such as aspiration pneumonia have been linked to poor oral hygiene in elderly patients. This clearly shows how important it is to address oral health as part of overall health care, particularly for senior citizens.
Now, as my colleague has explained you about aspirational pneumonia and periodontal disease, other diseases include peptic ulcer disease. Oral health status has been linked to peptic ulcer diseases. And uh, coming to drugs, unintended adverse drug reactions are known to occur in every organ of the body and are often mistaken for objective sign of underlying diseases. Now, another important aspect that concerns elderly is herbal supplements. While they may not be considered drugs, but various other supplements such as ginkgo and kava, they may cause lingual dyskinesia, gingival bleeding, hypersalivation, and they may be of concern to the dentist. Now, one important thing that the dentist should explain to their patients is the denture adhesive used by patients. Now, some of the dental adhesives used by patients contain zinc, and this may lead to zinc toxicity and and calcium and the reduction in level of calcium. The balance may be disturbed, which may cause neuropathies as well as anemia. And patients of head and neck tumor receiving radiation therapy may have a poor quality of life due to stomatitis and mucositis, diminished salivary gland function. Seeing all these cases, we may conclude that an interprofessional care consisting of nurses, dietitians, dentists, physicians, pharmacists, and patient and family at the center is of utmost importance in treating the patient. Now, concluding our presentation.
Concluding this presentation, I would like to say that dental professionals play a crucial role in the holistic care of geriatric patients. By working as a part of a multidisciplinary team and focusing on both oral and systemic health, we can significantly enhance the quality of life for our elderly patients. Aging brings unique challenges, but through collaboration, prevention, and education, we can ensure that our older population remains as healthy and as vibrant as it ever was.
Now, besides all this, patient education is of utmost importance. Patients should be educated about the medications and the interaction of medication with oral and systemic health. The patient should be taught that mouth infection can enter the bloodstream and affect overall health. Infected gums can equal a hidden sore the size of palm of your hand. Mouth sores that do not heal could be oral cancer. And good oral health can reduce the risk of pneumonia, help control blood sugar levels, and help prevent heart attack and stroke.
In addition to patient education, the awareness among professionals is also very important. in order to reduce the chaos in life of geriatric patients. Thank you for your attention.
Thank you so much.
Hello, good afternoon. This is Dr. Monisha Hossain, the co-presenter of this presentation. Here I am presenting Geriadent and special healthcare dentistry and overview in Bangladesh perspective. The key presenter of this poster is Professor Dr. S.M. Salahuddin Al-Azad. So here I am forwarding to the next. So as we all know about the Geriadent, this is an aging which is defined in chronological, physical, and social term, which is indicating the changes which is people are anticipating with their over the period of the age, leading to the functional and physical or contextual disabilities. So Geriadent is the delivery of dental care to the older adults, involving the diagnosis, prevention, and treatment of several problems which is associated with physiological aging and the other age-related disease as a part of their interdisciplinary team and other healthcare professionals. So this is the geriatric health is a comparatively less explored and more ignorant sector globally. So thus which we are doing in this Geriadontics. So moving to next, let's say about that the oral health, which is apparently neglected, like I said before, in elderly, which is because of the multiple reasons, such as like the other overall comorbidities, like the non-communicable disease or communicable disease and others, and also leading to the poor access and the dependency, which is occurred based on their aging. So some of these factors are leading them to the lower accesses to the oral health, which is apparently impacting the overall quality of life. So leading to these elder people, one of the common context among the elder people in case of the oral health, which is the edentulism, which is known as the complete loss of the teeth. So this edentulism highly impacted their overall quality of life, which is apparently impairing their daily life and social life because this edentulism they lack of confidence and they usually tend to avoid the social activities because they feel embarrassed, obvious reason. So not only the edentulism, but also these people, they also suffer from other causes, right? Which we also know that. And based on all of these contexts, especially the the low middle income countries like Bangladesh, people are very tend to have the very less service utilization for their dental care. So that's why this wide awareness and the accessible facilities is very important for the better quality of life of these frail people. So as per the edentulism, there are multiple stages. So as per the final stage, there is the leading to the periodontal disease, which is representing obviously the poor oral health care. So this edentulism is also affiliated with other nutritional deficits and significantly impairing their overall quality of life. So based on the previous research, we also found that this edentualism is also associated with increased mortality. So that's why this edentualism is very much important at the current scenario because this is increasing their mortality rate, and also this is impacting their regular life. So here we are seeing a radiographic image of a frail patient who is also suffering from the partial edentulism. So also in this frail patient, one of the prominent major significant condition among these elderly people, which is oral cancer. And basically oral cancer is more prevalent in male people. And obviously this is more prominent in male because of the random use of tobacco, smoking, and other risk factors. But nowadays, it is also prominent that women are also suffering from oral cancer for obvious reason or using the tobaccos mostly. And this oral cancer is more prominent in the lip region and leading to the oropharyngeal region also. Here we are seeing an image of oral cancer, which is affected the right mandibular region. So usually this frail patients management is very important because this group is already very vulnerable. So this group of people should be treated with special care, and which is the motto of our this event and the following our foundations. So that's why we are working for the betterment of the treatment of these frail people. So definitely the amount of care we should ensure for a random or adult people, we should ensure more consultation and more handle with care for this frail group. So here we can see, here we are talking about some several methods that we should improve for the oral care of these elderly people. Some of the method is basically including the public health campaign. The rule is very simple. The more aware someone is about their conviction and the following consequences, the ratio to the healthcare access will be more. So this should be our first and foremost goal. But based on all of this, we also should focus on the financial consideration because not everybody belong to a sufficient belong to having the sufficient financial backup, because we all know at the age of their elderly, most of the people have lost from the family. They ended up in the child home, or they ended up in the old home age, and they ended up having the not enough financial abilities. So while we should ensure the better oral health care for this group of people, we should definitely keep this financial consideration in our mind. So here, in the betterment of this sector, we always should have the parallel methods incorporating the government and private for the betterment of these access and the benefits of the oral health care. And moreover, we should incorporate the better technologies as the world is developing every other day. We should include the mobile technology, the telemedicine, the adoption of the utmost advanced technology for accessing them to the better oral health care. And also, we should ensure that these oral healthcare should be available in the primary root level. But while ensuring this dental healthcare, we are definitely supposed to facing some barriers, which can be active, which can be passive. But we also should have the management of these barriers. Like these barriers are one of the common barriers. Is definitely like I already announced, I already discussed about it. The potential cost. So that's why the cost should be a potential barrier, and as well as the lack of awareness among these people. So we should work on this particular progress or the particular points, and also we should work on the secondary level oral healthcare policies, which is leading to the implementation of these oral healthcare programs, like following to the hygiene plans. So these are some of the plans we should do as a preventive method before we leading to the treatment procedures. Here we are seeing some clinical images of some frail people. A common treatment which we are doing at the moment in Bangladesh, that is providing a particular dentures. So it is mostly related to the corrective occlusion of edentulous state. So here we are supporting them very much appropriate thermoplastic dentures, which is heat curated complete denture and implant supported prostheses and over denture. Majority of the rural and semi-urban old age population, since they have the habit of having tobacco and the smoking and snuffing the white leaves, so they are apparently ended up leading to the oral cancer. Here we can see an almost very much affected denture. This is the implant supported prosthesis picture in a radiographic way. Here is the after plan, the after supplying the denture. So the significant portion of the geriatric patients suffer from the periodontal disease, which I already said, and which is apparently leading them to visit the general dentist. So in that case, there should be no hard and fast protocol for the post-hospital care. So we definitely should focus on the rehabilitation, because once you are supplying the denture to the patient, your work is not done over there. We should definitely have a proper protocol and definitely have some specialized.
Good evening, everyone. The topic of our paper presentation today is sleep apnea and gerodontology, a comprehensive approach for senior care. So, as we all know, that sleep apnea is a quite serious condition that is affecting millions of older adults, wherein breathing stops repeatedly as well as starts during the sleep. Now, the risk of apnea keeps on increasing with advancing age, and thereby it impacts the overall health as well as the quality of life. Now, gerodontologists are crucial. How? Because they help in identifying as well as treating sleep apnea using custom-made oral appliances that provide a non-invasive and effective solutions. Now, according to apnea hypopnea index, it can be classified from mild to severe form based on the scoring from less than 50 to more than 30. Now, it is classified into two types. One is obstructive and another is centrally mediated. So in obstructive sleep apnea, it is more common of the two form and is commonly seen in the geriatric population. It is mainly characterized by repetitive episodes of complete or partial upper airway blockade during sleep. Now, we can say that in normal airway, the passageway surge is open and there is a continuous unobstructed airflow from the nasopharynx towards the oropharynx. But however, in case of sleep apnea, due to the flaccidity or laxity of muscle with the advancing age, the soft palate drops back and completely contact with the posterior pharyngeal wall, thereby resulting in the obstruction of airflow. Second is centrally mediated sleep apnea, wherein the airway is not blocked but the brain fails to signal the muscles to breathe. Why? Due to the instability in the respiratory control center due to certain pathologies like stroke or myotrophic lateral sclerosis. In between the obstructed and the central sleep apnea, there lies a third complex that is the mixed or the complex sleep apnea. According to a survey that was done by United States of America, the prevalence of the obstructive sleep apnea, it rapidly increased with advancing age, chiefly seen between 45 to 65 years of age, and amongst gender it is commonly seen in females as compared to males. Also, if we talk about the symptom, it is generally seen that the symptoms are more worse during the nighttime as compared to the daytime, wherein the patient has loud persistent snoring and witnesses multiple pause in breathing. There is choking or gasping of air, as well as restlessness in the sleep. While daytime symptom it includes early morning headaches, daytime sleepiness, poor concentration, irritability. Now, diagnosis, it mainly requires a thorough clinical examination as well as history taking, and the most reliable indicator being the relative, that help in telling about the history of repetitive episodes of snoring or obstructive breathing. Also, physical examination of the oropharyngeal structure is important to check for any growth, neoplasm, or other muscular disorders. The gold standard among all is the polysomnography test. And apart from it, there are multiple modalities like oxyhemoglobin saturation, chest wall effort, submental EMG, blood gas evaluation, fiber optic nasopharyngoscopy, etc. Now, management. Management can be classified into two types: medical management and surgical management. According to the medical management, it firstly required waist load exercises, continuous positive air pressure management, pharmacological agents like modafinil, and oral appliances that are mainly concerned with the gerodontologist. Surgical method mainly includes oropharyngeal surgery like distraction osteogenesis, mandibular advancement, or nasal surgery include adenoid surgery, septal deviation surgery, or nasal surgeries, etc. Now, if we talk about the prosthodontist approach, firstly we have an mandibular advancement appliance. So these appliances mainly help in movement of the mandible in a more forward position that thereby helps in increasing the patency of the airway as well as keeping the musculature in a more taut position and prevent its collapse during sleep. Second is the tongue retaining devices that helps in holding a tongue again in a forward position, which further tautes the muscle of the soft palate and helps in the airway being open during sleep, and also prevents the tongue from falling backward, thereby reducing the risk of airway obstruction. Third is palatal lift devices. These are devices that are generally used to treat conditions such as velopharyngeal insufficiency. They mainly work by physically lifting the soft palatal velum towards the posterior pharyngeal wall and thereby obtaining a proper closure of the seal of the velopharyngeal port. Now, there are certain advantages of sleep apnea devices as compared to various medical or other surgical modalities. Firstly, it helps in it is a mainly a non-invasive procedure if we compare it with comparison to devices such as your CPAP. Also, these are quite portable and convenient, became small in size, lightweight, and easy to travel. They have an increased comfort because patients often find it difficult to wear a CPAP mask for a longer duration of time. They do not make noise like large machines such as CPAP, and has patient often reports of better compliance. But if I talk about the disadvantages, these are less effective for severe cases and can be used for only mild to moderate cases. Patient often complains of jaw discomfort, pain, as well as TMJ problem due to prolonged use. Dental side effects are often seen like bite change in bite alignment or tooth movement, and patient often require regular adjustment, and this may not be often covered in the insurance. Now, regarding complete denture as a mandibular advancement appliance, it is a systematic review that was conducted by Preetha Krishnamurthy et al., wherein the study about the impact of complete denture mandibular advancement devices in management of completely edentulous obstructive sleep apneic patient. Now, in herein, they basically observed that in patients who have completed dentulism, the changes in the anatomy of upper airway during sleep are seen, and they influence the postural rest position of mandible, the tongue, and the muscular tone. And there is a decrease in the occlusal vertical dimension following loss of teeth, which further results in reduction of the lower facial height, rotation of mandible with a reduction in the airway space. So, therefore, what they did was they fabricated a maxillary and mandibular complete dentures, and the with the maxillary denture in patient mouth, the face-boring cord was transferred in a Hanau wide view articulator. A 3 mm thick wax interocclusal record was made, and the maximum protrusive jaw movement was done, which was further dictated by the condylar guidance path of the patient. Then these mandibular dentures were mounted on the articular using the wax record. These wax record were then converted into a heat cure soft liner, as we can see here. Then, after fabrication of the soft liners, hole was drilled in the first molar region in the intaglio surface of the maxillary denture bilaterally, which passed through this wafer to the occlusal surface of the mandibular denture. Now, it was done so that these can be joined together using the help of brass screws that pass through both of these holes. So, therefore, when the patient when the patient sleeps at night time, he has repetitive episodes of apnea. So, this protrusion of the mandibular audit advancement helps in tauting the musculature of the soft palate and thereby preventing its drooping. And when they did a follow-up for a period of 15 months, they observed that there was an improvement in the baseline AHI index for the post-treatment AHI. The reviews as well as literature regarding this method is limited, and further studies need to be conducted, but a fruitful could be a potential method to improve the symptoms of the sleep apnea in completely dentulous patients. And at last, I would like to conclude that effective management of sleep apnea in older adults require a multidisciplinary approach, including medical and surgical intervention. Early diagnostic, customized treatment are very crucial in improving the overall quality of sleep. Complete denture can be effectively utilized as a mandibular advancement device because these are a non-abrasive approach for airway patency and hence help in enhancing the sleep quality and improving the apnea symptoms, therefore offering a practical solution for geriatric care. These are my references. Thank you.
You're muted, ma'am.
Hi again, everyone. A huge round of applause to participants for displaying in-depth scientific knowledge showcased so creatively in all their paper presentations. As we approach end of day one of the Geriadent 24, I extend sincere gratitude to our mentors, Founder Secretary, Federation of Special Care Dentistry, Dr. Priya Verma, our FSCD President, Dr. Srinivas Namineni sir, and the chairperson of our Board of Geriatric Dentistry, Dr. Guidance throughout every step of our journey, all the way from conception to realization of this initiative to mark October month as the International
I think there is a network issue from ma'am's side. She'll join back.
Hi again. On behalf of the Vice Chair, I would like to thank the Geriatric Board and take this opportunity to thank the faculty and students for their contribution to make this conference Geriadent a grand success. Please do join us tomorrow at 4 p.m. to gain from the expertise of national and international speakers. Thank you, everybody.